Hi, my name is Bev Schechtman. I am Vice President of the Doctor Patient Forum, and I'm finally getting to the video I've promised you guys for probably 6 weeks, maybe 2 months now. This is about the DSM and the OUD, opioid use disorder diagnosis, the criteria to diagnose a patient with opioid use disorder, and how they're actually manipulating the criteria in what I believe is a fraudulent, scientifically fraudulent way to misdiagnose chronic pain patients who don't really qualify for an OUD diagnosis with OUD to push us onto Suboxone. That's the long and short of it. So what I'm going to do is I'm going to explain to you what the DSM is. I'm going to show you the actual criteria, and then we're going to go through each criterion, each one of them, and I'm going to either play a clip or show you a slide or somehow an article to show you how they're saying, people like Kolodny and these other anti-opioid people are teaching doctors how to manipulate those different criteria to diagnose us with opioid use disorder. Okay, so let me start at the beginning. The DSM, Diagnostic Statistical Manual. This is done by the American Psychiatric Association, the APA, not to be conflated with the APA, American Psychological Association, I think it's called. So this is APA, and this is the manual, really their Bible of what they consider a mental health diagnosis and the criteria involved in how to diagnose it, and then often the treatment. So the last manual that was done prior to this most recent one, right now we're up to the DSM 5 TR. I think that means like text review. The DSM 5 was done in 2013. The DSM 5 TR was updated in 2022. It wasn't enough of a change to make it a DSM 6. So it's just the updated DSM 5. Before that, the last one was in 1994, the DSM 4. So there was a long period of time before they updated this in 2013. And now there's a lot to tell you about the DSM. I'm not going to say it in this video so much because I want to give you a different video about that. But I'm going to talk about in that video the conflicts of interest, what their rules are on disclosing their financial conflicts of interest, how the work groups are quite conflicted, and what I actually think about the DSM as far as what their purpose is and what they're actually using it for. So that's going to be another video. This video right here is showing you the criteria for OUD. So opioid use disorder is a subset of substance use disorder. This was created in DSM 5, this category of substance use disorder diagnoses. This was what I have been told was an attempt to sort of separate out addiction and dependence, because before that, really dependence was addiction diagnosis in this country. So supposedly they did this for good. I don't really think that they did. We'll talk about that in the other video when I discuss that and their motives. So what they did was they made this category called substance use disorder. Now it's important to understand there is no addiction diagnosis in the DSM. There's zero diagnosis of addiction. Addiction, they usually say, is defined as continued use despite ongoing harm. So that's usually the accepted diagnosis. Now, substance use disorder is on a continuum. There's mild, moderate, and severe. I believe there's 11 criteria. 2 to 3 is considered mild. 4 to 5 is considered moderate. More than that is considered severe. I always thought SUD diagnosis meant addiction. I've recently learned that it does not. That mild SUD does not mean addiction. You live and you learn, right? But I don't think that they even understand that as far as across the different specialties. I think that opinion differs depending on who you're talking to, but supposedly that's the accepted thing, that moderate to severe means addiction, mild does not mean addiction. I'm going to share my screen and I'm going to show you the 11 criteria, because there's one caveat that I need to explain to make sure that you see. Okay, so first let me read this to you. The DSM-5 checklist of diagnostic criteria for opioid use disorder, a subset of substance use disorder. It's defined as a problematic pattern of opioid use leading to clinically significant impairment or distress as manifested by at least 2 of the following occurring within a 12-month period. Now, before we go through all of them, when they're talking about withdrawal and tolerance, they say this criterion, so tolerance and withdrawal, are not considered to be met for the individuals taking opioids solely under appropriate medical supervision, meaning you should not be able to diagnose someone taking either opioids for chronic pain or even Suboxone or methadone for OUD with this mild opioid use disorder just because there's tolerance and withdrawal, because that is going to happen with anyone taking daily opioids. So they put that caveat in there, much to the dismay of people like Andrew Kolodny and Prop, but that's beside the point. We're going to go through each one really quickly, and then I'm going to go back and show you one by one how they say to diagnose someone with OUD for chronic pain patients who take their opioids exactly as prescribed. Let's go through the diagnostic criteria. Number one, opioids are often taken in larger amounts or over a longer period than was intended. Number two, there is a persistent desire or unsuccessful effort to cut down or control use. Number three, a great deal of time spent in activities necessary to obtain the opioid, use the opioid, or recover from its effect. Number four, craving or strong desire or urge to use opioids. Number five, recurrent opioid use resulting in a failure to fulfill major role obligations at work, school, or home. Number six, continued opioid use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of opioids. Number seven, important social, occupational, or recreational activities are given up or reduced because of opioid use. Number eight, recurrent opioid use in situations in which it is physically hazardous. Number nine, continued opioid use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the substance. Now, here's the other ones we spoke about. Tolerance, as defined by either of the following. A need for markedly increased amounts of opioids to achieve intoxication or desired effect. Or B, a markedly diminished effect with continued use of the same amount of an opioid. That's tolerance. Withdrawal, as manifested by either of the following. A, the characteristic opioid withdrawal syndrome. Or B, opioids or closely related substance are taken to relieve or avoid withdrawal symptoms. So then again, it says, notice that those two criterion are not considered to be met for these individuals taking opioids solely under appropriate medical supervision. And then it just goes on how to specify actual remission from an opioid use disorder diagnosis. And then current severity have different ICD-10 codes, which is a diagnostic code. Mild is 2 to 3 symptoms, moderate 4 to 5, severe 6 or more. So this is what happened. Andrew Kolodny had a webinar in September. And in this webinar, Andrew Kolodny said that SAMHSA, the mental health organization in our government, they have this NSDUH, which is the drug survey, how they come up with the numbers of how many have what diagnosis for drug use. Okay. So in this webinar, he said that they've realized that there's really 9 million people with opioid use disorder in this country. They've always said 2 to 3, but now there's 9. And 5 million of them, 5 million, are chronic pain patients who take opioids exactly as prescribed. And I was like, come again? What? What do you mean? Because there's only estimated to be around 10 million chronic pain patients who take opioids. So you're trying to say that half of them have opioid use disorder, even though they take it exactly as prescribed. So I was like, what in the world? So then he goes on to say, well, that doesn't mean they're addicts. It just means that they have an OUD diagnosis and they need to be given that treatment. Meaning, as always, the solution is always Suboxone. So he's really advocating for taking stable patients off of their medication, taking it exactly as prescribed to give them Suboxone, which makes absolutely no sense.
I just want to show you a paper that just came out very recently, about 3 weeks ago, showing that among the millions of Americans who have opioid use disorder, 62% of Americans who have prescription opioid use disorder take their opioids as prescribed. I just want you to think about that for a second, because for many years we were told to think of the patient who's on opioids who might have opioid use disorder as being a small subset of the patients who misuse, who don't take as prescribed, at a subset of the misusers have opioid use disorder. What this is telling us is that 62% of people who take the opioid exactly as prescribed meet criteria for at least mild opioid use disorder. But for those who are addicted, we have to see that they can more easily access effective treatment. That first-line treatment that we should be making readily available to patients with opioid use disorder is really buprenorphine, which is a really good treatment option for the chronic pain patients who are stuck on opioids. Many of them do quite well. I actually believe that I actually know that there are about 5 million Americans with opioid use disorder who are getting their opioids from doctors, and that 62%, the majority of them, are taking their opioids exactly as prescribed. I am not calling people with chronic pain on opioids addicts, drug abusers. What I am saying is that the evidence tells us that the majority have opioid use disorder. And what that means doesn't mean they're an addict. What that means is that for many of these patients, it's very difficult for them to come off. They've been on opioids longer than they ever anticipated. And as doctors become more cautious in their use, many of these patients are getting cut off. They experience excruciating withdrawal, and many of these patients are in a very bad place right now. I don't think that as a nation we're doing an adequate job of helping people like you and like the millions of others who are on long-term opioids.
So what would you say if I told you that there are 1 million patients out there right now who are taking their medicine compliant? They should not be labeled patients with opioid use disorder. They're taking it the right way. They're living productive lives. Why would they be ripped off their medicine?
So I'm not saying that they should be ripped off their medicine. In fact, I think that the vast majority may never be able to come off of opioids. They're going to need opioids for the rest of their lives. I think that many of these individuals are under the impression that opioids are helping them, because what they'll say when you talk with them is that if it weren't for the opioid, I wouldn't be able to get up and walk my dog. If it weren't for the opioid, I wouldn't be able to get out of bed and take a shower. I would not be able to function. My pain would be so excruciating. I need the opioid. That is what they say, and they are not lying when they say that. They mean it. But that is also the same thing that someone who is a heroin user is going to say. In other words, with the person who takes opioids chronically, before they've taken their next dose, as the previous dose is wearing off, they are feeling awful. And then they take a dose and they feel much better. And in their mind, the opioid is treating their underlying pain problem. What I believe is that the opioid is treating the withdrawal pain hypersensitivity of the previous dose wearing off. And lastly, what I will say is why I do think it's important to call it what it is. And if people meet the DSM criteria for opioid use disorder, why we should use that label. I know there are many doctors who feel that they're stigmatizing a patient. They're putting a brand on them by giving them the stigmatized diagnosis. But I think that when we don't use the correct diagnosis, that many patients wind up not getting treated. And for the people with the more moderate to severe opioid use disorder, the ones who have difficulty controlling their use, many are going to be at high risk of death if we don't give them the proper diagnosis. It's hard to see that people get evidence-based treatment if you don't really give them the proper diagnosis.
Now remember, the addiction diagnosis used to be use despite harm. Well, because there's no actual addiction diagnosis anymore, I was like, wait a second. He just said they have OUD, but they're not, his words, addicts. So I was like, wait. So I messaged Maya Solovitz and I'm like, I'm so confused because I must have missed the fact that opioid use disorder does not mean addiction. Right? All this time I thought it did. And I just want to say something here. This push to change language, to remove stigma, I'm okay with that. But I'm not okay with removing a word and having nothing to replace it with, or replacing it with something that doesn't mean the same thing. For instance, opioid abuse or drug abuse. I get it. Abuse is a negative word. But what did you replace it with? Misuse? Well, misuse doesn't mean what abuse used to mean. Misuse just means taking other than how the doctor prescribed. It could mean taking 5 minutes early. It can mean taking less. So no, it doesn't mean the same thing. And what else did you replace it with? Use. but use doesn't mean abuse. Misuse doesn't mean abuse. So you removed a word from the language and you replaced it with a very nebulous term, misuse, and it's being used to harm chronic pain patients now. Because now they're like, oh, this is an opioid misuse crisis. No, it's not. That's not true. You sometimes hear people say chaotic use, problematic use. Fine, I'm okay with that, but I'm not okay with it because nobody's using the same terms. Nobody knows what to use. Nobody knows what to say. So they're all saying misuse and it's incorrect. And so now it is harming chronic pain patients. So I'm not okay with removing stigma from one group and putting it on another. I'm not okay with the concept of this whole public health of one group needs to be willing to sacrifice themselves for the good of another or the whole. I'm not okay with that. I've never been okay with it and I never will be okay with it. Who are you to tell me I need to sacrifice myself for you? I don't think it's fair, especially when there's no evidence that me sacrificing myself would even help you, which is really what has happened in this community, in this country, when it comes to chronic pain and opioids and other opioid use, what used to be called abuse. So I messaged Maya and I was like, wait a second. I don't understand because Andrew Kalani said all these people have OUD, but they're not addicts. So how does that, I don't even get what that means. So does OUD not equal addiction? I'm going to read to you what she said here. She said, it's supremely annoying. Addiction is substance use disorder, moderate to severe, AKA meets criteria for what was formerly wrongly called dependence. SUD, mild, is what was formerly known as abuse. Basically the equivalent of college binging, which can be risky, but most people outgrow. Most people outgrow addictions too, but even more outgrow college binging, for example. What this does is it makes the prevalence, this is really important. What this does is it makes the prevalence of addiction appear way higher than it is and confounds statistics after the DSM change if you don't specify severity level. It's better than calling it dependence, but it creates the issue of overdiagnosing and making it difficult to track. So before we get into the actual clips of each criterion and then showing you how they're teaching doctors to manipulate and really lie to diagnose chronic pain patients fraudulently with OUD, I'm going to play a clip from this Australia webinar about deprescribing. It was from a few years ago. These doctors have joined forces in the past with Mark Sullivan and even Jason Doctor and Jane Ballantyne to discuss this issue about chronic pain and opioids, and they're really on the same page here. But this clip is really good to show you. It's kind of going to set it up for what the rest of this video is going to be about as far as why they have to kind of manipulate the criteria when diagnosing pain patients. So first I'm going to play this clip and then I'm going to say one more comment and then we're going to get on with the rest of it.
But if you're going to consider DSM-5's substance use disorder criteria, it's important to understand that in the context of prescription opioid use disorder, i.e. painkiller addiction, that you cannot use tolerance and withdrawal, which are the very same criteria that can be used to diagnose physiological dependence. DSM-5 requires us to make a diagnosis of substance use disorder. Now, there are 11 criteria, and because you cannot use tolerance and withdrawal to make a diagnosis of prescription opioid use disorder, you can only use the other 9, and you need at least 2 criteria out of the other 9 to get a diagnosis of substance use disorder.
Okay, so this is really important because they really want us all on Suboxone. Now, is it because they're paid for that? I mean, I know that webinar was absolutely 100% an unencumbered grant from Indivior, but I don't think that's necessarily why all doctors want their pain patients on Suboxone. I think similar to the Michigan Opioid Collaborative at University of Michigan, as they call it, it's the way out, right? It's the way out of this mess. It's the off-ramp. I've seen it said quite a number of ways where doctors are just afraid to have us on it. They don't want us on long-term opioids anymore. They don't care necessarily about the actual evidence, which is that 16 or 17 studies now show, regardless of dose duration or combination of medication, it is more dangerous to cut a patient off opioids against their will than to allow them to remain on. That doesn't matter. They want them on Suboxone. Is there evidence that Suboxone works well for pain long-term? Why, no, there isn't. That doesn't seem to matter. They will continue to say it's amazing for pain. It's amazing for everything. It's like a miraculous molecule that cures everything now, right? So they're manipulating the diagnosis. Of course, Paul Coelho has said, I have a low threshold for diagnosing a chronic pain patient with OUD. And so they're taking criteria and they're manipulating it, right, to diagnose us when we shouldn't really be diagnosed with it. And this exclusion of dependence and tolerance is a problem to them. They don't want that. And I'm going to show you later how Mark Sullivan had a slide at a recent American Society of Addiction Medicine conference where he said so, that they want that exclusion removed when it comes to chronic pain patients. So really, the exclusion will only be there for patients with OUD on Suboxone and methadone. So if they already have OUD and they're on medication for that, then they can't be diagnosed as far as active disease. They want that exclusion removed when it comes to pain patients, which is ridiculous. But that set us up for the rest of this webinar. So let's get into it. Let's go back to that first criteria. And again, number 1, opioids are often taken in larger amounts or over a longer period than was intended, aka escalating use or for a longer period of time. I'm going to play a clip for you to show exactly how they make that fit for chronic pain patients. So this was the Australia webinar again.
Then we have escalating use. So, you need a history of doses going up. And I would argue that really, if you're having to do more than 2 dose escalations to treat uncontrolled pain, you're really then talking about something other than just pure pain management. And therefore that's introducing the concept of a substance use disorder.
Okay, so what he's saying here is that escalating use, which is supposed to mean like someone who's taking opioids not as prescribed and they keep going higher and higher and higher and higher and it's never enough, it's taking more and longer. But a pain patient, he said, fits in this category if they've had it in an increase in their dose 2 times or more. Now, why is that a problem? Well, they teach every doctor, start low and go slow. So if you start low, go slow means escalate it slowly. All pain patients are going to have more than 1 or 2 escalations, really, especially if they have to go a bit higher than they anticipated at the start with the doctor. So they're literally teaching the doctor to do exactly what's going to cause that pain patient to be diagnosed with opioid use disorder. And so you might have a pain patient who's been on opioids for 15 years and they've had their dose increased twice. So he's showing you right there. That's it. That's at least that criteria for that pain patient. Okay, so now let's go to the next one. Let's go to number 2. There is a persistent desire or unsuccessful effort to cut down or control opioid use. So these are people who want to stop that can't. Okay, that makes sense, right? Inability to stop.
The kind of the facets that might indicate a prescription opioid use disorder rather than a traditional heroin use disorder. So the inability to cut down and reduce. So really that for me, that refers to previous failed deprescribing efforts.
Okay, so failed deprescribing. But what if the patient doesn't want to deprescribe? What if the doctor's always encouraging, like you hear these experts, Claude and whatever, say every patient should try to taper to see if it does well?
Given all this, I think that any chronic pain patient that is taking an opioid should be encouraged to do a very slow, very gradual, self-directed taper to make sure they're benefiting from opioids before they continue to take all of these risks associated with opioid use and chronic pain. So first,
okay, so if they try and it doesn't, all of a sudden that qualifies them for an OUD diagnosis, or at least this one criterion, right? Failed deprescribing, so they fit that category. Again, everything they're telling doctors to do with patients, or they're telling patients to try, will end up getting them diagnosed with opioid use disorder. I'm going to play another clip. This is from Paul Coelho from Oregon, also addressing this.
Delaying a taper for a month or 2 is reasonable, particularly with new patients who don't have aberrancy or florid opioid use disorder, and you're trying to gain and build trust. Pausing a taper is permissible during stressful times, the holidays, weddings, deaths in the family, etc. However, once you start the taper for high-dose opioid patients, you should never go backwards. Pause, but don't take them back up to high doses. Sometimes, not always, the litmus test for opioid use disorder is the inability to taper slowly.
Okay, so also he forces everyone to taper when they're over a certain amount. So here's two different doctors saying you got to get the patient to taper. And if they don't do well, that's a litmus test for at least this criteria for OUD. Now I'm going to show it to you also in this article from Andrew Kolodny that he recently wrote that came after his webinar. This was just actually like a month or so ago, called Screened Out, How a Survey Change Sheds Light on Iatrogenic Opioid Use Disorder. This is what I was talking about before. I want to read this one part to you. The three most common DSM-5 criteria for opioid use disorder reported by people who took opioids as prescribed were: 1, unsuccessful efforts to cut down or control use. That's another doctor, a third person, showing how that second criterion can be actually applied to chronic pain patients. But it's intended to mean people who try to cut down and can't, but that's not what they say it as. They want you to taper when you don't want to, or once you've tried it just to see, because they tell everyone to try it and it doesn't go well. Well, right there, you're setting yourself up for an OUD diagnosis, or at least that criteria number 2. Okay, so let's go to number 3. A great deal of time is spent in activities necessary to obtain the opioid, use the opioid, or recover from its effect. And now we're going to show how they apply that to pain patients. So first, we'll start with Andrew Kolodny's article again. We read before, the 3 most common DSM criteria for OUD reported by people who took opioids as prescribed were the first one we mentioned before: unsuccessful efforts to cut down or control use, opioid craving, and spending a great deal of time obtaining or using opioids or recovering from opioid use. Okay. To be sure, assessing whether people using opioids for pain have OUD is challenging. Some people receiving long-term opioid therapy who were identified as having OUD may have met the criteria for mild OUD because of difficulty tapering off opioids, which he said I showed you before. In addition, some patients probably reported, this is important, some patients probably reported spending substantial time obtaining opioids because many prescribers have become more reluctant to treat patients with opioids for long periods. So he's literally, again, it's the system that set it up. Patients have a hard time finding a provider when they lose one, or they're abandoned, or they're forced tapered because of the system, because the doctors are afraid, because of the way you've set it up. So that, again, is a third criterion that a pain patient will be diagnosed because they have to call 17 doctors like Danny Elliott did when they're abandoned. That is substantial time spent. That's not because they have a disease or whatever it is you call it. That's not because of a disease of addiction. That's because it's a failed and broken healthcare system. You made it this way. You caused this. Number 1, 2, 3 that we just went through is all because of the system you created, and you're actually diagnosing a pain patient with a disease because of it? Nope. It just makes me so angry. Okay, so here he's talking about this great deal of time spent.
Time, I've described time, so ever-increasing amounts of time acquiring, using, recovering from opioid use, albeit prescription opioids.
So again, the same thing, right? A lot of time spent obtaining a prescription. Well, we wouldn't have to spend a lot of time obtaining a prescription if you didn't make it that way, right? Okay, so that's 1, 2, and 3. Let's go to criterion number 4. Craving or a strong desire or urge to use opioids. I already showed you in that article from Kolodny where he said that's one of the most common thing with prescription opioid use disorder, that pain patients crave opioids. I've heard others say that desire for pain relief is synonymous with drug craving for addiction, which is ridiculous. No, it's not at all. Just because you say so doesn't make it true. Then I'm just going to show you this one here.
Ongoing craving refers to use outside medical sanction or doses outside medical sanction. So, doctor, I've run out of my meds. I've taken them early because I had a headache and bad day.
Right there. What if your doctor only gives you 5 breakthrough pills a month back when they used to do that? And you have a kidney stone and you take it and it's different from what he told you to take it for. But you call and ask for more medicine because you're passing a kidney stone and they say no. So now all of a sudden, once again, their stringent rules are setting a pain patient up to be diagnosed as cravings. Well, I'm going to tell you, if you pass a kidney stone, Dr. Andrew Kolodny, I don't care how many times you say Tylenol works just as well. I guarantee if you had a Vicodin in your cabinet, you'd be taking it also. That doesn't mean you have an opioid use disorder. It means you're in excruciating, unrelenting pain. And yeah, it's outside of what the doctor prescribed, but they're not prescribing anymore. So what is a pain patient supposed to do? Here's the thing in all of these. If you treated pain adequately in these patients, then they wouldn't qualify for any of these criteria. But you knew that, didn't you? Okay, and then I'm going to show you one more example of this specific one to do with craving. And this is Mark Sullivan from PROP. This was at a ASAM, American Society of Addiction Medicine conference, I think in July. And here's his slide. From opioid dependence to opioid addiction, role of craving. One indicator of this progression to opioid use disorder is craving. Research on craving that used single item scales found a relationship among craving, negative affect, and opioid misuse. Research using multi-dimensional measures of craving has found that the desire and intention to use prescription opioids and craving for relief from negative states like pain were significantly associated with having experienced pain over the past 3 months, pain severity, and number of pain locations and pain interference. So they're just going to do these mental gymnastics all over the place to make it now desire for pain relief is craving. It's the same thing as a drug craving for someone with substance use disorder. Okay, so let's go to the next one. Number 5, recurrent opioid use resulting in a failure to fulfill major role obligations at work, school, or home. Now, this is a really big one because we've often heard Anna Lemke, Jane Ballantyne, they love to talk about pain patients playing the sick role. They love to do that.
The professional patient, where illness, you wrote illness as an identity and a right to be compensated. Explain a little bit about the professional patient. And I can't even blame them. After reading what you wrote, it's hard to even blame them when there's so many incentives to be a professional patient nowadays.
Right. So this is always a difficult construct to explain because it seems like it's blaming the patient. And really, as you noted, so much of my book is really trying to understand this behavior that on the outside seems just, so maladaptive. But basically, professional patients are people who have real problems. Now, maybe their problems aren't medical problems.
Let me digress to that second because there's terms that you didn't go into in your book, but I hear them all the time. Fibromyalgia, corpodynia, where somebody comes in and says they have fibromyalgia and there's no identifiable disease, no identifiable trauma, injury, anything else, but they say, I heard here, there, and everywhere, but there's no lab testing. There's no way to confirm or deny. In your opinion, is that real or is that sort of this narrative? Is it a narrative or is that a real disease? In your opinion, not that we know for sure.
Yeah. So in my opinion, it's not real.
It's a narrative.
It's a narrative. It's a way that people are communicating real distress. So I think these people have real distress, and it's a narrative in the culture that they can adopt to communicate that distress. Here's the thing: I have a lot of patients with fibromyalgia, and I would never challenge that narrative. But what I do challenge is the use of opioids for fibromyalgia. First of all, there's no evidence that it helps them. That it helps.
And this is what they're referring to, right? Taking on the role of just being sick and having your spouse take care of you because somehow we all enjoy this sick role that they talk about. I'm going to play one clip here.
And the inability to meet obligations. Now, I interpret that as the inability to.
I interpret that. Inability to meet obligations. You interpret that as.
perform a role as a result of adopting the sick role.
Inability to perform obligations because of a sick role. So I've heard Franklin, I believe, or Sullivan say that means not going back to work. So doing well, there's that famous clip of theirs, doing well is doing well. It doesn't mean lying on a couch. Doing well means going back to work, right?
David and I and Jane are on a panel trying to decide when we're going to bless low-dose opioid therapy. And all I wanted to say is that doing well is doing well. And a lot of times patients will say to this, you know, they may say, I've got 9 out of 10 pain, I've got, you know, significant depression and anxiety, but I would be much worse if you took away my opioids. My sense is that to be doing well on the drug, you have to be doing well. Like, you have to have a good mood and good function, and you're succeeding at, most importantly, at the important roles in your life. That's doing well. Somebody who says, well, I'm in bed most of the day, but I'd be in bed all the day if I weren't on opioids, that is not a good candidate. And those people should either be tapered or transitioned to buprenorphine.
No. You don't get to tell a pain patient what doing well is to them, because you certainly don't tell that to someone with OUD. You let them decide. No, any pain patient who becomes a pain patient and has to go on disability never intended for that to happen. They didn't enjoy it. They didn't adopt a role. Most of us would have rather done anything other than lose everything in life and have to miss all of our children's things. And so you're going to again take something like a sickness and an illness and pain and say, oh, you missed your kid's recital. That qualifies you as this criterion for opioid use disorder. You guys should be ashamed of yourselves. You really, really should, but you're not, because I don't know, you guys have no soul or something. Absolutely soulless. Let's go to number 6. Number 6, continued opioid use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of opioids. I'm going to show you a clip here.
And then the loss of personal relationships. So I think it's fair to say that, chronic high-dose opioids and chronic pain constrain personal relationships.
No, high-dose opioids are not constraining personal relationships. How about the fact that they're sick? Let's go to number 7 here. Important social, occupational, or recreational activities are given up or reduced because of opioid use. It also shows that in the clip that I just showed you from Australia. And then number 8, recurrent opioid use in situations which are physically hazardous.
Persistent use despite hazards. So again, we're starting to look at aberrancy here. So, needing to steal prescription pads or drugs, and lying to the prescriber or the pharmacist to get your drugs, doctor shopping, that kind of thing.
So I get stealing, obviously, that is a problem, and lying to the doctor could be a problem. But doctor shopping, that kind of thing, often means having to see multiple providers because you lost your provider. Or what if you have a regular doctor and then you have surgery and then you end up in the hospital on the ER? That's another doctor. And so, no, doctor shopping does not mean addiction. It doesn't mean OUD. It doesn't. But here's another way you see it. They continue to set it up for sick, marginalized, chronically ill patients to fit every single one of these criterion, even if they take their medication exactly as prescribed, because just being sick will cause a lot of these, like taking the sick role and losing interpersonal relationships. But also the system that you guys have set up has caused all of this. You broke the system and then you blame us for it and diagnose us for it and punish us with Suboxone is what happened. So long and the short of it. Number 9, continued opioid use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by the substance. Let's go back to this clip here.
So again, reduced engagement in life in the face of overwhelming opioid use.
Okay, so that was the last one before withdrawal intolerance, which we know does not apply. So I'm going to play this entire clip here. It's going to kind of sum it up for you.
The 11 criteria. So again, reduced engagement in life in the face of overwhelming opioid use. Time, I've described time, so ever increasing amounts of time, acquiring, using, recovering from opioid use, albeit prescription opioids. And the inability to meet obligations now as a result of adopting the sick role. and then the loss of personal relationships. So I think it's fair to say that, chronic high-dose opioids and chronic pain can strain personal relationships. So those are just some ideas about how you might tie in the presentation you would see of prescription opioid use disorder into the criteria, the DSM-5 criteria.
So he's actually saying, I'm teaching you how to use what's in chronic illness and pain to give a OUD diagnosis.
For opioid use disorder. Bearing in mind, you cannot use tolerance or withdrawal to make a DSM-5 diagnosis of prescription opioid use disorder. Now, if we follow on from what Simon said, so we understand that buprenorphine is an opioid.
So here comes the solution, which I'm going to show you more in the next webinar I do in the next video. I'm going to just play this one more clip here for you.
Okay, so buprenorphine and its role in opioid agonist therapy. So remember, I said earlier that you can really only use opioid agonist therapy, buprenorphine, once you've made a diagnosis of opioid dependence. What that means on a patient-by-patient basis can be variable and depends on really the interpretation that every individual clinician makes when faced with that patient. I personally, when I'm considering the diagnosis of dependence in this context, and when I'm considering opioid agonist therapy for patients, I rely on excess harm, so that's an OMED of more than 100, and the inability to cut down, so a previous failed deprescribing episode, and possibly multiple dose escalations, so at least 2 dose escalations. And those are the criteria that I commonly use to make a diagnosis of prescription opioid use disorder, and therefore open the doorway to the provision of opioid agonist therapy with.
And there it is. So that kind of sums it up. He went over some of the things we already went over. So those were his 3 most common, that Australia doctor. Lodney's 3 most common were unsuccessful efforts to taper, opioid craving, and spending a lot of time using opioids or recovering from opioid use disorder. Here's the thing that I just showed you. 6 or more is severe. You can't use those other 2. 9. So there's 9 other criteria that I just showed you how they manipulate patients taking it exactly as prescribed to be diagnosed with all of those 9. Every single one of those. So every pain patient taking opioids exactly as prescribed with their teaching can be diagnosed with a severe opioid use disorder to open the door to Suboxone. Right? And that's what the next part of this video is going to be about. I'm going to show you the clip of how that webinar was funded with an unencumbered grant from Indivior, of course. And I'm going to play different clips for you from those doctors about Suboxone and being the way out. I might show you a bunch of different clips about it because there's so many different doctors who say that. And then I'm also going to then go on to show you how the financial conflicts of the DSM, because this all leads us to think, like, did they know that they were going to do this? Was this intentional? I think a lot of it was intentional when you start looking at the funding behind the DSM and those who were on the work groups and how much they took from industry. I think a lot of it was intentional. That doesn't mean I think every doctor is intending to lie, cheat, and steal, but I do think a lot of doctors, like the ones teaching the other ones like this, Kolodny, Claw, Brummett, Sullivan, Franklin, Lemke, Ballantyne, Berland, all of these that we know the names of, I do think every single one of them knows exactly what they're doing. Exactly what they're doing. And it's just disgusting to lie. Again, this is how they diagnose chronic pain patients with opioid use disorder when they actually don't really have it. I thank you for watching this part of this video. Hopefully I'll get the next one out to you within the next week. Thank you so much for your support. You guys have a great day. Thanks for watching. So as it turns out, if you rewrite the definition of addiction, suddenly everyone's addicted. Who knew? But it's fine because they also sell the cure. And did I mention that the same industry that sells this cure also funded the diagnosis? What a coincidence. My name is Bev Schechtman. I am Vice President of the Doctor Patient Forum, and this is our DSM video part 2. If you missed the first one, I highly recommend you watching it. It is all about the DSM-5, the OUD diagnosis, which first came out in 2013, and how doctors like Andrew Kolodny are actually teaching other doctors to manipulate the criteria of opioid use disorder to misdiagnose, fraudulently diagnose pain patients with opioid use disorder. So these trainings, they don't just bend the criteria, they actually weaponize them. And this isn't a rare occurrence anymore. It's one of the more common things we hear from with chronic pain patients, that you've gotten an opioid use disorder diagnosis. It really is mainstream, and it's being taught in continuing medical education courses as the right way to deal with chronic pain patients. So just as a quick recap, I'm going to show you 2 quick video clips that I showed in the DSM Part 1 video.
So if we look at the criteria, I've kind of listed some of the kind of the facets that might indicate a prescription opioid use disorder rather than a traditional heroin use disorder. So the inability to cut down or reduce. So really that for me, that refers to previous failed deprescribing efforts. Ongoing craving refers to use outside medical sanction or doses outside medical sanction. So, doctor, I've run out of my meds, I've taken them early because I had a headache and bad day. And then the use despite persistent harm. Now, if you remember that a high OMED of more than 100 milligrams a day puts people at an elevated risk of death by over a factor of 10. And this is also compounded when you consider the risk of death associated with polypharmacy. So therefore, you've got that risk of harm, and you've got persistent opioid use, albeit for my pain, despite that risk of harm. Then we have escalating use. So, you need a history of doses going up. And I would argue that really, if you're having to do more than 2 dose escalations to treat uncontrolled pain, you're really then talking about something other than just pure pain management. And therefore, that's introducing the concept of a substance use disorder. Persistent use despite hazards. So again, we're starting to look at aberrancy here. So, needing to steal prescription pads or drugs, and lying to the prescriber or the pharmacist to get your drugs, doctor shopping, that kind of thing. Next slide. So a reduction in activity. So, with substance use disorder, we have a kind of a loss of peripheral activities so that the entire focus is on either acquiring, using, or recovering from the drug. And that reflects the salience that we talked about for the ICD-11 criteria. So again, reduced engagement in life in the face of overwhelming opioid use. Time, I've described time, so ever increasing amounts of time, acquiring, using, recovering from opioid use, albeit prescription opioids. And the inability to meet obligations. Now, I interpret that as the inability to perform a role as a result of adopting the sick role. And then the loss of personal relationships. So I think it's fair to say that, chronic high-dose opioids and chronic pain constrain personal relationships. So those are just some ideas about how you might tie in the presentation you would see of prescription opioid use disorder into the criteria, the DSM-5 criteria for opioid use disorder. Bearing in mind, you cannot use tolerance or withdrawal to make a DSM-5 diagnosis of prescription opioid use disorder.
So as you can hear, he really is teaching doctors how to manipulate the criteria, not to screen a patient, a chronic pain patient on opioids to see if they have opioid use disorder, but starting with the opioid use disorder diagnosis and working their way backwards, right, to how to diagnose a chronic pain patient with opioid use disorder, even if they're not really showing the true signs. So that sort of raises the question, right? Why are they so desperate to make this OUD diagnosis fit? Why are they trying so incredibly hard to inflate the number of people labeled with opioid use disorder? We're going to hear clips from a recent webinar from Andrew Kolodny, our very favorite. This was a webinar back in 2024 in September. And in this webinar, he claimed that 5 million chronic pain patients now meet the criteria of OUD. And these are people who take their medication exactly as prescribed. And this is based on the NSDUH survey, which we're going to go into later, because that in and of itself was manipulated in order to inflate these numbers. So I'm going to play a quick clip here. This is Dr. James Davies. He's a PhD. He's out of the UK, and he's been researching the DSM for years. So I just want to play one quick clip that he said, because I thought this was so accurate. Now, of course, he's not talking about just the substance use disorder category. He's talking about the DSM as a whole.
Created the illusion of a psychiatric epidemic.
Yeah, that's just such an important point. It's an illusion. And I want you to keep that in mind for the rest of this video. Now, this video is quite packed with information. There's a lot of details. I tried to cut out the information that wasn't as necessary, but I just feel like it's so important to understand all of the aspects of this to see how exactly this happened and how we got to where we are today. So what we'll cover in this video is basically the questions that don't really get asked, which are, why would they want to inflate the opioid use disorder statistics? Like, who benefits from those numbers? Who funded these diagnoses? And why isn't there transparency about the people who created them? We're going to walk through the DSM's history, how the opioid use disorder diagnosis was rewritten, who was paid to write it, and how it was just quietly embedded into risk algorithms like NARC's care with no patient input, no way to challenge it. And finally, we'll show you why we filed a federal citizen petition to the FDA demanding transparency and oversight of NARC's care. So this truly is why and how this happened to pain patients. We know what happened. We know why it happened. We know how it happened. We know who funded it, who caused it, who continues to make it happen. And we actually think we even know how it needs to be fixed. Our next huge step is figuring out how to make those fixes happen, but that's for another video. We're not going to be addressing that today. Okay, so to understand how we got here, we have to start with the DSM itself. So the DSM is the Diagnostic and Statistical Manual of Mental Disorders. It's really the Bible of psychiatry. It's done under the APA, the American Psychiatric Association. There's also American Psychological Association, but this is the Psychiatric Association, the APA. And it tells doctors like what counts as a disorder. It's not just used to diagnose, but also to determine things like insurance coverage, research funding, medical coding, and of course now who gets labeled as addicted. So here's just some key history points. In 1980, the DSM-3 came out, and this really revolutionized psychiatry. For the first time, and in 1980, diagnoses were built into checklists of systems. It wasn't just interviews or doctor's impressions. It was checklists, criteria for diagnosis. I'm going to play a clip here from Dr. James Davies.
As Robert Spitzer openly confirmed to me in our interview, and actually I think this is my favorite quote of all. He said the following: "Our team was certainly not typical of the psychiatric community, and that was one of the major arguments against DSM-3. It allowed a small group with a particular viewpoint to take over psychiatry and change it in a fundamental way." What did you make of that criticism? What did I make of that charge? Well, it was absolutely true. It was a revolution. That's what it was. We took over because we had the power.
So that says everything, really. There was a small group of experts who had the power to redefine normal. And they did. They truly redefined normal. So let's talk about the DSM when it has to do with addiction. There's all the other categories, depressive disorders and all of those other categories, but we're going to focus, of course, on addiction more in this video. But when the DSM was released in 2013, the addiction section was absolutely overhauled. The old categories in the DSM-4 were substance abuse and substance dependence. And the DSM-5 combined those things into SUD, or substance use disorder. This diagnosis was built around 11 behavioral criteria, things like using more than intended, or wanting to cut down but being unable, or spending time recovering from use. And you heard before how they manipulate pain patients by saying, oh, well, if we want you to taper and you don't want to taper, that's difficulty cutting down. And that's what we mean by manipulate it. In the DSM-5, if a person met just 2 of the 11 criteria, they're then diagnosed with mild substance use disorder. This was on a continuum: mild, moderate, severe. In the case of opioids, it's opioid use disorder. And from there, the entire medical and legal system treats you as addicted. Once you get this label, then you're seen a certain way, you're seen as higher risk, and you're treated a certain way in the medical and legal system. One interesting aspect here is I always thought OUD meant addiction or SUD meant addiction. But some experts don't agree with that. Like, they can't even agree on the definition of addiction. Some say that moderate to severe OUD is what addiction used to mean, and some say all of it is addiction. Some say moderate and severe get Suboxone and mild doesn't. I mean, if there's no scientific consensus here, even if experts can't agree on the definition of this disease, how is it being used to flag pain patients and databases, cut them off of life-saving medications, force them into treatment facilities and into the addiction medicine treatment center black hole of this country? I want to play a clip from Dr. Paul Coelho. He's out of Oregon. We've played a bunch of his clips before. I'm going to apologize in advance because I tend to listen to these on 2 times speed, and this I accidentally recorded on 2 times speed. So you might have a hard time hearing it, but we're going to try anyway.
I and Julie, my partner in our practice, we have a low threshold for the diagnosis of opioid use disorder, iatrogenic.
Okay, so he said we have a low threshold for opioid use disorder in chronic pain patients.
Disorder, when a patient's dose is above 240 MED and they're struggling with the taper.
So if their dose is over 240 and they're struggling with the taper, they get slapped with an OUD diagnosis, which that's not even in the DSM. So he gets to make it up, which I believe is scientific fraud. But basically, I mean, the way it comes down to it is if you're in pain and you're saying your medication works and you won't lower your dose, then that's now called opioid use disorder, which goes back to the manipulation of the diagnosis to push a treatment, because then you know the treatment is always Suboxone. And if you heard before, the exclusion of withdrawal and tolerance. So in those 11 criteria, if you are under the care of a doctor, you can't use the withdrawal and tolerance as 2 of the criteria to diagnose somebody with an opioid use disorder. But even that Dr. Sullivan from Prop, he doesn't even like that. He wants to rewrite the DSM all over again, and this time make sure that the protections for pain patients are removed. He wants that only for medication for opioid use disorder, like Suboxone. The bottom line is they're not following the DSM. They're trying to reshape it to make sure every pain patient on opioids qualifies as having OUD. This isn't medicine. This is policy manipulation dressed up as science. And before we get into the funding and the lack of transparency, I want to address something. It's not like this just happened. There were experts who warned that this would happen. You know what's happening now? There were experts who warned that the diagnosis was too vague. This isn't just hindsight. They ignored these warnings, or they knew it was going to happen, and that was their plan anyway. But as soon as the DSM-5 was released, there were leading psychiatrists, researchers, addiction experts who raised the alarm about the vagueness of the new diagnostic criteria for the entire DSM, but specifically for substance use disorder, especially when it applied to opioids. Just a few of the people who raised the alarm. Alan Francis, he was the chair of the DSM-4, and he said that the new criteria would pathologize normal behavior, and he predicted an epidemic of overdiagnosis. Maya Salovitz, as we all know, she's a friend of pain patients, and she said years ago that the DSM-5 criteria would end up mislabeling pain patients as addicted, even if they were taking their medication exactly as prescribed. And Mark Lewis, I love Mark Lewis, he's a neuroscientist. He called the diagnosis pseudoscientific and overly moralistic. And they were right. Under the DSM-5, you can be diagnosed with opioid use disorder just for needing your medication or for having symptoms of pain. So they used this vague criteria to create this illusion of an epidemic, not of misuse, but of medical patients misclassified as addicts or addicted, giving this illusion of an epidemic. Kolodny keeps saying that there is an epidemic of addiction, but the statistics don't support him. The statistics never supported that. They needed that to happen, so they created it. Right? So let's look at how Andrew Kolodny, one of the most influential voices in modern opioid policy, applies the diagnosis today. I'm going to play a few clips from Andrew Kolodny's webinar from back in September.
I just want to show you a paper that just came out very recently, about 3 weeks ago, showing that among the millions of Americans who have opioid use disorder, 62% of Americans who have prescription opioid use disorder take their opioids as prescribed. I just want you to think about that for a second, because for many years we were told to think of the patient who's on opioids who might have opioid use disorder as being a small subset of the patients who misuse, who don't take as prescribed, that a subset of the misusers have opioid use disorder. What this is telling us is that 62% of people who take the opioid exactly as prescribed meet criteria for at least mild opioid use disorder. What this really means is that every patient you come across who's on chronic opioids, you should really be considering or screening them for opioid use disorder. That there are, I actually know that there are about 5 million Americans with opioid use disorder who are getting their opioids from doctors, and that 62%, the majority of them, are taking their opioids exactly as prescribed.
Now, here's the thing. That's exactly what Maya was talking about, right? This is exactly what we're trying to show. And the actual true definition of addiction is use despite harm, like continued use despite harm and escalating use, inability to stop, but really continuing to use despite harm to yourself and others. And the thing is, this doesn't fit there. So they manipulated that too. But what he's saying is fraud, in my opinion. This is scientific fraud.
I am not calling people with chronic pain on opioids addicts, drug abusers. What I am saying is that the evidence tells us that the majority have opioid use disorder. And what that means doesn't mean they're an addict. What that means is that for many of these patients, it's very difficult for them to come off. They've been on opioids longer than they ever anticipated. And as doctors become more cautious in their use, many of these patients are getting cut off. They experience excruciating withdrawal. And many of these patients are in a very bad place right now.
And there's that part I was talking about, right? He said they have OUD, but they're not addicts. So OUD doesn't mean addiction anymore. So when Narcs Care reads opioid use disorder, or when a risk score algorithm reads OUD, or a doctor sees OUD in their chart, do you think they're like, oh wait, this is mild OUD, so they don't have an addiction? That's not how this works. And he knows that's not how it works. So let's listen to his last quote, because this is super important. This shows really their motive here. Like, this shows why he would want a patient diagnosed with OUD taking their medication exactly as prescribed.
Lastly, what I will say is why I do think it's important to call it what it is. And if people meet the DSM criteria for opioid use disorder, why we should use that label. I know there are many doctors who feel that they're stigmatizing a patient. They're putting a brand on them by giving them the stigmatized diagnosis. But I think that when we don't use the correct diagnosis, that many patients wind up not getting treated. And it's hard to see that people get evidence-based treatment if you don't really give them the proper diagnosis.
And that's what it is. We need them to get the proper diagnosis, to get the evidence-based treatment, and we all know what that is, right? Suboxone. So the label really isn't about describing a patient's condition. The label is about unlocking a treatment protocol, right? And that treatment is Suboxone. And if you want to give it, it's easiest to give it if you give a diagnosis that justifies it. Giving an OUD diagnosis is a surefire way to just get the patient off of opioids. You could say, I'm not allowed to prescribe it to you. You have opioid use disorder. And then if the patient doesn't go on to Suboxone, at least they're out of the doctor's hair and off of opioids. Later in this video, we're going to go deeper into the question, why are they pushing so hard to apply this OUD diagnosis to compliant pain patients? Why are they so incredibly determined to classify this as an addiction? And part of the answer definitely is Suboxone, and we're going to play a ton of clips and go into that in detail. But there's another layer to this that many don't fully realize. The opioid use disorder narrative also became the foundation of the national opioid litigation. This is what we call the litigation narrative. Once the DSM-5 criteria was in place, their survey data like the NSDUH, it's an annual drug survey. We're going to talk about that later from SAMHSA. That was inflated as well. Once they had these inflated numbers, now they could say, look, millions of people have opioid use disorder. Look how much these skyrocketed, right? And that created the legal framework to say pharma-caused addiction epidemic, even among people who took it exactly as prescribed. And they got to say that this was an epidemic of addiction, which is something you hear Kolodny say a lot, right? And this narrative helped bring in almost $60 billion in litigation settlement funds that you see flowing into the states now. This was all part of that narrative and all part of what they needed for that narrative. And one thing people don't really understand is the abatement plan, the process. One of the data points that they used to determine how much money each state or each location got was prevalence of OUD diagnosis. And they did that based on the NSDUH survey, which we're going to talk about soon. So the more OUD you had, the more money you got. Now, they needed the DSM-5 OUD diagnosis. They needed that to happen to inflate the statistics. They needed the survey to change in order to inflate those numbers. And they needed everyone to understand that Purdue was at fault. And everything fell into place. And I do believe this was all part of the litigation narrative planned by lawyers and pushed by these expert witnesses for years. So experts didn't just warn about the vague nature of the DSM-5 criteria. They also started asking bigger questions about the conflicts of interest. Who funded the development of the DSM? We know the APA did it, but who funded it? Who sat on those work groups that created these diagnostic criteria? And did any of them have ties to the very industry that profits from the labels they created? So, today there's such intense scrutiny and a ridiculous obsession on Purdue Pharma and the Sacklers and the doctors and the pain advocacy groups who took money from opioid makers. But that raises a question, like, why hasn't the same level of scrutiny ever been applied to the DSM itself or to addiction medicine? And this is something I'm obsessed with because they turn a blind eye to it. Did people only care about industry influence when it was about pain doctors and pharma because they could sue because of that? What about the people who created the very diagnosis that's now used to justify cutting people off of opioids and replacing them with Suboxone? So how much influence did pharma actually have on the DSM? And could it be part of the reason why pain patients are suffering today? I know this is a lot of information, but stick with me here and let's break it down. The DSM isn't just a book of diagnostic criteria, right? It's a manual that controls what's considered a disorder and who gets treatment, who gets cut off, and who gets labeled for life. So how was it written? Like, what was the process? You'd think there would be like public records, open hearings, or some sort of transparency into the process of who shaped the definitions, how, why, what the discussion was, all of that. But that's not how it worked. When Dr. James Davies, who investigated the DSM development process, decided to investigate the DSM, and when he started researching, what he found out, I don't think it's what he thought he would find out. So let's see what he found. I'm going to play a few clips.
There was very little documentary evidence chartering the processes that the committees who wrote DSM followed when they put that manual together. So I quickly realized, if I were to write some kind of reconstruction of events, then I would have to go and speak to the people who wrote DSM. I wanted to speak to the people who wrote DSM-5, So I contacted the APA and said, could I do so? I want to understand the processes that went on behind the scenes, as I did with DSM-3 and DSM-4. And it turns out that I wasn't allowed to speak to anyone involved in DSM-5 because all of them were asked to sign confidentiality agreements prohibiting them from speaking to anybody, any academic, any journalist, about what went on behind the scenes in the construction of DSM-5. So I said, well, can I just consult the archives then? You know, I mean, I'm a researcher. And they said, oh, well, you can't do that either. And I said, well, why not? Because they've all been embargoed for 20 years post-publication. So we cannot work out what went on behind the scenes. And so the APA has a vested interest in keeping this hidden. And I think what I discovered was that when you get behind the scenes, things look a little different to how they've been represented.
You heard that right. The people deciding whether you or a loved one has a psychiatric disorder, they had to sign an NDA. And the materials where they were discussing it to see how they, came up with these diagnoses, they're locked away for 20 years. I mean, what actually happened to transparency? How is this allowed? I have no idea. I mean, can you imagine if Purdue Pharma had created diagnostic criteria and then we're like, oh, trust us, but we can't show you our notes? It would be a national scandal and there would be a gazillion Netflix documentaries. But when the APA and the DSM and all of that, no one cares. No one bats an eye. Really, where's the public outrage? Beth Macy, the book? No? Really strange. This secrecy wasn't just about protecting their intellectual property in the process. It was about protecting financial conflicts because once people started digging, they found the money trail. And let me tell you, it was something to see. Just like a little snapshot, a little summary of the DSM secrecy. There were no meeting notes, no public debate transcripts, an NDA signed by workgroup members, and archives that are embargoed for 20 years. Yet this is what's being used against pain patients to cut you off your medication and put you onto Suboxone. So in 2025, this country is pretty much obsessed with financial ties between doctors and opioid manufacturers, right? It's on the news even almost nightly now. But that's only when it comes to pain care. We've seen entire exposés about doctors who took money from Purdue or who spoke at pain conferences. But when it comes to workgroup members who wrote the DSM criteria, the ones diagnosing half the country with psychiatric disorders, you would think their financial disclosures would be made public, right? I mean, the process might be secret, right? But the funding must be easy to trace, isn't it? Yeah. Not so much. It turns out that not only was the process of writing the DSM hidden, but the money behind it was hidden also. And the more researchers looked, the worse it got. So in 2012, before the DSM, about a year before the DSM-5 was released, Dr. Lisa Cosgrove and her colleague, Dr. Krimsky, investigated conflicts of interest among the DSM panelists. And what they found was absolutely staggering. Many of these payments were never disclosed to the public. I'm going to play a few clips from a podcast called Mad in America, where they were talking to Lisa and her colleague.
Yeah, I could start with kind of a little broader perspective on the research question. So I'm coming at it particularly from the drug side of things, from the pharmacology. I teach pharmacology for medical students, for residents, and for graduate students. And influential materials can have a very profound effect on the practice of medicine. Members of my team, we've been doing studies for the past, 8 or 10 years, looking at point of care databases like UpToDate and Dynamed, looking at Medscape. We've been looking at a lot of different information resources like the New England Journal, Journal of American Medical Association. And the general pattern is that the conflicts of interest is really important. The National Academy of Medicine says, if you're going to put together clinical practice guidelines that you can trust, you should have authors whenever possible that don't have a conflict of interest. And the American Psychiatric Association in their publications, they require that authors disclose conflicts of interest So we were a little bit surprised, maybe even a little bit mystified that the American Psychiatric Association, in publishing the DSM, didn't have the most recent version of the DSM, some sort of preface, some sort of information, even in small font. I'd be happy with it in 0.2 font about the conflicts of interest of the contributors to this. And that wasn't present. That information wasn't available. So we wanted to help them out, if you will, and get this information into the public domain.
One thing to understand is that the federal open payments database that we talk about often, and I'll put the link in the show notes here, that's where you can look up your doctor to see how much money they took from industry, from pharma, medical device companies, or whatever. The law that requires that industry payment disclosure didn't exist until 2014. And the DSM was published in 2013. So there really was no legal way to track payments during the years that this was developed. The only disclosures were voluntary, self-reported to the APA. And the APA didn't even verify them. When Lisa Cosgrove and James Davies dug into the DSM, let's see what else they found about these workgroup members.
Of the 29 members of the DSM-5 task force, the people who wrote and put the manual together, 21, it turns out, had financial ties to the pharmaceutical industry, including the chair of the DSM task force, David Cuffer, and the vice chair, Daryl Reiger.
21 out of 29. And listen to this next clip. This blew me away when I heard this. This is really important.
56% of the people who were involved on the advisory panels and the consultancy groups for the construction of DSM-4, 56% of them had one or more financial tie to the pharmaceutical industry. And then get this, on the panels that considered the disorders for which drugs are the first line of treatment, 100% had financial ties to the pharmaceutical industry.
100%. So he's talking about things like substance use disorder. In opioid use disorder, Suboxone is first line, right? It's gold standard. It's supposed to be given immediately the second you think someone has OUD. In groups like that, 100% of those people determining those diagnoses were funded by industry. So some of those ties are consulting fees, speaker fees, research funding, advisory board positions. And most of these were with companies that really directly stood to profit from the diagnoses these panelists were writing into the DSM. I don't understand why this hasn't been made into a scandal where anyone actually cares, other than there's just so much money being made that I guess, they're able to buy the government silence maybe. I don't know. It's crazy. Okay, so here's the next clip.
Shelley Krimsky and I first did our study in
this is Lisa Cosgrove.
Published it in 2006 on conflicts of interest in the DSM-4. We found that almost 60% in total of the authors had financial conflicts of interest.
So she's talking about the DSM-4 there.
Then a year before the DSM-5 came out, in 2012, we published a study looking at the conflicts of interest in the DSM-5. And at that point, the APA did institute a conflict of interest policy. I'd like to think that maybe our 2006 study had a small role to play in that, but they did, at any rate, they did have this policy. And yet what we found was approximately the same percentage of panel members had ties, and the ties were particularly strong in those areas for which pharmacological treatment was the first line intervention. And so, as Brian was saying, it is curious that, with the DSM-5 TR, given our past publications and their conflict of interest policy for the 2005, that they didn't have one for the TR version.
TR version came out in 2022. TR means text review. DSM-5 came out in 2013. And then the DSM-5 text review came out in 2022, just a few years ago. They made it a text review and not another one like DSM-6 because there wasn't enough new information there. According to what I found, there wasn't enough new information. And so instead they made it a text review or an update instead of the next DSM. This one last clip.
And can you remind me of the total amount that you found again? Was it $14 million? Was that right?
$14 million completely undisclosed. So the readers of the DSM wouldn't know this. So the American Psychiatric Association, unlike in their journals where this information, not the number amount, but at least, the names of the companies are listed, none of this information was available.
So that's a DSM-5 TR. $14 million, over $14 million in undisclosed financial conflicts of interest in the DSM-5 TR committee members. That's crazy. I mean, that's really, really insane. And it's something that needs to be looked into more than just these researchers. I think action needs to happen. Something needs to happen because it's harming people, not just in substance use disorder, but across the board. So the DSM wasn't just shaped by psychiatry. It really was shaped by industry. And then it was shielded by an organization, the APA, that profits from its use. One of them have said in one of their research that from the APA, their revenue went from 10 million to over 50 million because of the DSM. And again, while Purdue and doctors and pain organizations got investigated for any dollar, any payment at all, the DSM architects never did. There were no headlines, no Department of Justice probes, no abatement clawbacks. Instead, it was an industry-funded diagnosis of opioid use disorder, which is now being used to, of course, push Suboxone restrict care and truly drive litigation payouts. So this chart right here is just about the DSM-5 SUD workgroup members. I want you to see the ties they had to addiction pharma that they weren't required to disclose and who those companies were. As you can see, it's ties to Indivior, Alkermes. Indivior makes Suboxone, Alkermes makes Vivitrol, Braeburn, NIDA, and MOUD medication for opioid use disorder research teams. These are the people who created the very OUD criteria that are now used to deny pain care and to push Suboxone, benefiting the companies who paid them. But it didn't stop at funding the people who wrote the DSM-5 OUD criteria. Companies like Indivior, the maker of Suboxone and Sublocade, they also fund the training materials that now show doctors how to apply those criteria. Remember that at the beginning of this video, I showed you the recap of that. It was an Australian doctor talking about how to really weaponize the DSM criteria to fraudulently diagnose chronic pain patients. I want you to listen to the clip, a very small clip at the end of that webinar.
Whilst we're having a look at some of the answers, I actually want to give a thank you to the sponsors of this evening who have given an unencumbered educational grant to the organizers of the event, and that is Indivior, the manufacturers of Sublocade.
So there, we spent the entire hour and a half teaching you how to misdiagnose chronic pain patients with opioid use disorder to give them Suboxone. Oh, and by the way, we thank you for the unencumbered grant from Indivior. I mean, it's crazy. You can't make this stuff up. Just to connect a few dots for you, I want to point out one of the key DSM SUD panelists was Dr. Walter Ling. He's a psychiatrist out in California. He's received over $1 million from the addiction industry, pharma, 1 million, including mostly from Indivior. So again, Indivior funded the diagnosis creators, and now they fund the educational programs teaching doctors to use that diagnosis on pain patients. And they're also greatly benefiting from the litigation. Even though they were also sued tremendously several times, they're benefiting from those lawsuits because it's trickling right back down to them. And you hear about jails and Suboxone and Sublocade and all of that. They're benefiting from all of this, and they funded all of this. So let's go back to the DSM-5 TR a little bit, right? You heard Lisa Cosgrove talking about it. And after the backlash of the DSM-5's hidden industry ties, you would think that the next edition would clean things up. And as you heard from Lisa Cosgrove, it didn't, right? The transparency just got worse in some ways. Here's a chart that's just a side-by-side of some different data points from DSM-5 and the DSM-5 TR. So basically, kind of to sum it up, in the DSM-5, we had names of the workgroup members, but no money, no knowledge of the money. And the DSM-5 TR, we had the access to the funding, but the names disappeared. We didn't know who they were anymore. Again, quickly, the DSM-5 TR was published in 2022, and after the open payments law was in full effect. Remember, that was open in 2014. So for the first time, they had actual numbers for the funding. And when Lisa Cosgrove dug into it, again, let's look at what she found. Here's a chart that shows 60% were with pharma ties, so it didn't get any better, like she said. $14.2 million in industry payments just in 3 years. The names linked to the SUD panel were hidden. The conflict of interest disclosures by the ATA were not there. And the funding breakdown by company, again, was not there. So we don't even know, and the SUD group itself, how much they got and from what pharmaceutical companies they got it from. No idea. So even though that open payments law was designed to promote transparency, it seems like the APA found a way around it by simply not listing who worked on what, which means we really don't know. We don't know who wrote the updated OUD language, whether any of them had ties to Indivior or Alkermes, or how these updates may have benefited those specific products or policy pushes. All we know is there was $14.2 million in funding, no accountability. And as we saw earlier, this isn't some like obscure academic issue. This diagnosis is being used to justify forced treatment, Suboxone mandates, narcs care flags, and opioid litigation dollars. There are 8 to 11 million estimated chronic pain patients still on opioids right now, right? Easily 6 million or more have been forced off. We don't know how many because they don't count it, but I would imagine it's been that many. If something isn't done, those 8 to 11 million, because of all of this nonsense, are going to be pushed onto Suboxone, given a fake OUD diagnosis, or medically abandoned. Just a few more quick points I wanted to say. Even in the disclosures in the DSM-5, they didn't have to disclose, for whatever reason, unrestricted educational grants. In the open payment system, you could track an MD, but you can't track a PhD, which was a lot of the work group members. And if the work group members, like in the DSM-5, were from another country, like one was from France in the SUD group, you can't track that either because they're not in the open payment system. But even if, in an ideal world, even if we could access all of the names and we could trace the entire thing, like all the industry payments for every single panelist, whether they're an MD, a PhD, or in another country, would that be enough? Would that be enough? So Lisa Cosgrove was asked this question, and let's hear what she has to say about that.
I think most people, if you told them that eating a candy bar, a chocolate bar, increased longevity and increased your overall health, if they found out that that study was funded by Hershey, most people would be certainly skeptical. They wouldn't have to be schooled in conflicts of interest. And yet, sadly, when it comes to medicine, I don't think people are as aware as they could be of the ways in which these conflicts can result in imbalanced and sometimes inaccurate information.
You talked a little bit about the next version of the DSM. So if we look to the future, is it sufficient to have these conflicts writ large in the work, or should we go further than that and examine some complete split between industry and how it contributes to research and development and all those kind of things? Is it enough just to name these things, or should we go further than that?
Definitely, we should go further.
Yeah, just disclosing isn't sufficient. Just disclosing really, it's the management of these conflicts of interest is really important. And again, my dream and the National Academy of Medicine's dream would be, hey, you should get people that don't have conflicts of interest. That would be really important in this.
Imagine that. Imagine that, having people who don't have these conflicts of interest. Surely there's a lot of them. And that makes me think that they search for people with these conflicts of interest because these people are funded to make these changes. And we saw it in the CDC guideline work group. We saw it there too. We saw the lack of transparency. We saw the lack of disclosures and having to go back and do corrected disclosures and still not disclosing what they're supposed to. Just have people who are not financially conflicted this way. Seems like it shouldn't be that difficult. But, at the end of the day, we're not just really talking about transparency. We're talking about control. over a diagnosis itself. And if the people writing the criteria for opioid use disorder have ties to companies that sell Suboxone, then the system isn't really broken, is it? The system is built to be this way, right? And remember, this isn't just about politics, funding, or policy. These diagnoses have real consequences in the stories, and many of you know because it's happened to you, that once you're labeled with a psychiatric disorder like opioid use disorder, that label will actually follow you everywhere and dictate your treatment. I'm going to play a clip by Dr. Ellen Francis, who again was the chair of the DSM-4.
And many of these people do a lot better never getting a diagnosis, partly because once a diagnosis is made, it tends to haunt people for life.
There you go. I'm going to play that again.
They're never getting a diagnosis, partly because once a diagnosis is made, it tends to haunt people for life.
See, he knew that. And that's exactly what's happening to so many of us. And again, we'll tie this in later when we talk about narcs care, that it will haunt you for life. And even if you just have it for a short period of time, even if you're just given Suboxone, it's read as having opioid use disorder and you're haunted for life, right? So the diagnosis can follow you into your medical record, insurance status, and again, determine if you get care or if you lose care. I'm going to play a next clip by Dr. James Davies. This is another important clip. This is something I've said a lot. You know, you hear Gary Mendel talking about removing stigma all the time, calling it a chronic broken brain disease and how that's destigmatizing, which that makes no sense. Telling someone you're broken for the rest of your life is removing stigma? Yeah, I don't get it. But let's listen to what Dr. James Davies had to say.
I think it's very stigmatizing, actually. I think the medical model is more responsible for stigma in society than anything else. We've been led to believe the origins of stigma reside in a benighted public who are prejudiced against people who suffer. I think that prejudice, if there is any, to the extent it exists, has been exacerbated by the models of distress that have been foisted upon us over the last 30 years.
Yeah, I totally agree with him. Absolutely 100% agree. The medicalization of normal, typical behavior, regular drug use or substance use, whatever you want to call it, under the care of a doctor. This does not reduce stigma. This creates stigma. Telling someone they're broken for the rest of their lives, it's stigmatizing, especially when the diagnosis is based on behavioral judgments funded by industry and used to justify truly coercive treatment. So by hiding these names, hiding the funding, refusing to even reform their conflict policies, the American Psychiatric Association and the addiction industry didn't just rewrite the DSM. They rewrote the lives of millions of pain patients, as we see in the stories in my inbox every single day. So this next part of this video, we're going to be addressing this idea of manufacturing an epidemic. And remember earlier in the video when Kolodny claimed that 5 million chronic pain patients who take their medication exactly as prescribed now all of a sudden have opioid use disorder. Well, those statistics came from the NSDUH, which is the National Survey on Drug Use and Health, and that's under SAMHSA. So let's just take a little bit of a closer look as to how this survey works. Like what changed? How is it now being used to push a mass treatment narrative with pain patients truly caught in the crosshairs? You know, when I first started researching, it was like, oh, there's 2 to 3 million with OUD. And now all of a sudden, there's 9 million, 5 million are chronic pain patients who take their medication exactly as prescribed. That doesn't make any sense. So of course I had to go back and dig into it because it just doesn't make any sense. I don't know how else to say it. Let's first go back to the shift in narrative itself, right? Their goal was to rebrand this crisis, not one of an overdose crisis, but of an addiction crisis. If you hear Kolodny talk often, he'll say one of the greatest myths is that this is an overdose crisis, but he'll say, no, it's not. It's an addiction crisis. I'm going to just read a quote to you from, it was an article, I think it was a decade ago or so. It said, over the past decade, Kolodny has broken ranks with many physicians by insisting the epidemic is not one of drug abuse, but of addiction, born of the overprescription of extremely addictive painkillers to patients suffering from back and nerve problems and other kinds of chronic pain. So he really, really has focused on the fact that this is an addiction epidemic. Remember the quote before from James Davies saying they've created an illusion of a psychiatric epidemic. They've created an illusion of an addiction epidemic. And this was backed by statistics, right? They manipulated statistics to back their illusion. And those statistics, they changed not because more people were addicted, but because the rules for counting addiction changed. And this is the part that I don't think media truly gets, because they hear these things all the time. Addiction statistics spiked, blah, 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 but it's really not what happened. So let's go look briefly at the history of the NSDUH and how they rewrote these numbers. Do you know really between 2003 and 2014, if you look at the NSDUH survey, it showed no increase in non-medical use of prescription opioids. That's right. In the height of the OxyContin crisis, there was no increase in the non-medical use of prescription opioids. Can you imagine that? I'm going to quote Jacob Sullivan, a Reason article. I love Jacob. He was on our podcast. If I remember, I'll put the link in our show notes because he was phenomenal. From 2003 to 2014, the rate of non-medical use of pain relievers was remarkably stable. So what changed? Well, in 2015, something strange happened. They just changed the questions, right? That same year, the NSDUH added Suboxone, buprenorphine/naloxone, under the list of prescription pain relievers. And it wasn't just buprenorphine, the generic name. They listed Suboxone was the only name brand they listed, and it was under pain relievers. So here's the chart from NSDUH 2015 to 2023, and it shows Suboxone misuse, right? The drug that's used to treat addiction now had the highest misuse rate of any pain relievers listed in the survey. And then that misuse was then lumped in as evidence of pain medication misuse epidemic to then put people onto Suboxone. The real question is, why is Suboxone by name, a medication for OUD, listed as a pain reliever, not Belbuca, Butran, which are actual pain formulations of buprenorphine? Why is Suboxone the only brand name bup listed at all? It's almost like the survey was designed to inflate the pain medication misuse statistics so that more people can be diagnosed with OUD for litigation purposes and then be put onto Suboxone. Remember that the CDC guidelines came out in 2016. So here you have the DSM in 2013, the statistics changing in 2015. It all lines up with the litigation narrative. And there was another failure in SAMHSA's drug survey, even up until 2023. There was a recent Filter magazine article about it. What they said was the NSDUH continues to ignore illicit fentanyl, and instead it groups prescription fentanyl misuse together with it. So prescription fentanyl misuse is lumped together with illicit fentanyl. This makes the survey useless for overdose tracking, but great for pushing a narrative about prescriptions being the problem. And once you do that, once you change how a diagnosis is defined or how a survey counts behavior, you can no longer make fair comparisons to past data anymore. You've broken the trend line. So when you say, oh, look, a huge spike in OUD, look at this spike in misuse, that's not really pointing to reality because they're pointing to a recoded definition, right? And they did this on purpose. And honestly, in my opinion, that's probably the intended result, because you can't justify a massive policy change or new treatment mandates or billion-dollar litigation without first convincing the world there's a skyrocketing crisis. So they changed the criteria of the DSM in 2013. They changed the questions in the NSDUH survey in 2022. And just like that, like magic, the numbers shot up. not because the problem got worse, but because they redefined the problem to make it look like it got worse. So think about those clips we played earlier from Andrew Kalodny, right? With 5 million chronic pain patients taking their meds exactly as prescribed now have OUD. So now, thanks to the vague DSM criteria, the revised federal survey, millions of pain patients are being labeled as disordered, even though they take their medication exactly as prescribed. And in addition to all of that, this is sort of just an aside, but I found it interesting. Let's hear what Alan Francis has to say about self-reported surveys, because that's how the NSDUH is. It's just a survey, like a self-reported survey.
And the other thing is that epidemiological studies never count correctly. Epidemiology always miscounts because it's a telephone interview or a self-report thing on the internet that doesn't account for clinical significance. Having painful symptoms is not equivalent to having a psychiatric disorder. Those painful symptoms have to cause clinically significant distress or impairment. And that can't be done in a self-report interview on the internet or by telephone lay interviewer.
Just as Alan Francis said, these surveys were never meant to be diagnostic tools. These are blunt instruments that are now used as the foundation for public health policy. Forced tapering, Suboxone expansion, and even opioid litigation payouts. I'm going to play one of my absolute favorite clips of all time from one of my absolute favorite experts that we've had on the podcast. We've actually had him twice. I'm still editing the second one, but this is Dr. Stanton Peele, who I have so much respect for and absolutely adore. But listen to this. This is my favorite clip.
So we've created a solution for a problem that we invented.
That's right.
It's created a whole new problem, and it causes death.
I mean, can you say it any better than that? Like, it's, I don't know. Perfectly said. So the DSM creates the diagnosis, the NSDUH creates the epidemic, and Suboxone was packaged as the solution to a problem they built from the ground up. Congratulations if you stayed with me this entire time. I know that was a lot of information, and we have finally reached the end of our DSM video part 2. So let's just do a quick recap here. We invented a vague diagnosis, handed it to a panel full of pharmacies, locked the receipts in a vault for 20 years, and then rewrote a federal survey to make it look like millions of pain patients were suddenly addicted. Because nothing says public health like redefining reality and calling it data. And now that the fake crisis has been manufactured, well, surprise, there's a miracle treatment waiting for you, brought to you by the same companies funding the diagnosis, the training, and the narrative. Next month, part 3 will come out. And in part 3, we follow the pipeline, how they turned a diagnosis into a billion-dollar business, how pain patients became marketing targets, and how NarxCare is now enforcing it all, silently, automatically, and algorithmically. But here's the thing. They built this system assuming we would never find out, except we have. So part 3 isn't just about exposing what they did. It's about taking the power back. See you there. The citations will be linked in the show notes, and I will also have part 1 in the show notes in case you missed it. Thank you so much for watching. Have a great day. In the last 2 videos, we pulled back the curtain on how the opioid crisis didn't just happen, it was manufactured. In part 1, we exposed how a small circle of so-called experts hijacked the DSM, weaponizing the definition of opioid use disorder to fraudulently diagnose pain patients with OUD. Stable patients taking their medication exactly as prescribed, labeled disordered, not because of science, but because the label served a purpose. The DSM-5 blurred the line between dependence and addiction, and that was not an accident. That was a plan, because when you criminalize the act of needing pain relief, you turn medicine into ammunition. In part 2, we followed that fallout. We showed how those same corrupted definitions were baked straight into national surveys like NSDUH, inflating statistics by pretending Suboxone was a misused painkiller, ignoring the tidal wave of illicit fentanyl deaths, and turning the story of responsible pain care into a convenient political scapegoat. We also showed how the DSM changes weren't just sloppy. They were profitable. I know, surprise, millions in undisclosed industry dollars flowing into the work groups that rewrote the rules. No disclosures, no oversight, definitely no shame. Because when you create more patients on paper, you create more customers in real life and customers for life. And when you create more fear, you create more funding. Which brings us to now. The FDA is about to revisit these studies on long-acting opioids in what's called PMR, post-marketing reviews, and PROP is back again, dusting off that same broken definition using inflated data, the same old tired, and they're asking for their already denied petition from 2012 to relabel long-acting opioids. But this time, we're not pretending this is about patient safety. This time, we're following the money. So in part 3, we show you exactly how the architects of this crisis cashed in through expert witness gigs, government contracts, and lawsuits built on the wreckage they helped create. This was not a public health strategy. It was a business plan, and a brilliant business plan. And the people paying the price were never the ones at the podium or cashing the checks at the bank. They were the ones in the hospital beds, in the cemeteries, and forgotten in the data. They were the ones with no voice. Until now, we are the voice for the voiceless, and we won't stop. Let's get to it. Let's follow the money. While this fake OUD epidemic was being built through the DSM criteria and the tweaks for the NSDUH survey, there was a whole other industry forming around it. And it wasn't just pharmaceutical companies. It was the addiction medicine key opinion leaders, the ones who shaped the narratives, testified in trials, and shaped federal policy. These are the Andrew Kolodny, Ballantyne, Anna Lemke, Gary Franklin, Mark Sullivan, and more. These were serial expert witnesses in opioid litigation that were used to shape this policy and made a gazillion dollars in the process. So I'm going to play a clip here from Dr. Andrew Kolodny when he was interviewed on a podcast not that long ago.
And now you have a private practice as well as your position at Brandeis and Heller.
Well, about almost 2 years ago now, I stopped seeing patients. I very infrequently see patients now.
Because you were too busy.
Yes, I was doing my research, my teaching, and then when the litigation against opioid manufacturers began to get going, and at first I was volunteering my help on some of these cases, but it became it required too much time, and so that's when I stopped doing clinical work. And
So he stopped seeing patients basically to be a full-time expert witness in opioid litigation. And, you know, I think he makes $750 to $800 an hour. The range tends to be between $500 and $1,000 an hour. You know, he says he volunteered at the start. I don't believe him. These are not volunteer gigs. These are very, very profitable. So another one of my favorite clips, I want to play this clip from when he was an expert in the Johnson & Johnson trial, because people ignore this conflicts of interest. They often don't disclose it, even in like academic journals and even studies. They don't usually like to disclose it. They don't think it's an actual financial conflict of interest, which it is. I love this clip. This is the lawyer questioning Kolodny.
So you're getting paid in this case $725 an hour as well, right?
I'm getting paid in this case $725 an hour, yes.
Okay. For all the work that you've done, correct?
That's correct.
And at the time of your deposition, you were asked how much you had been paid up to that point in time, and your testimony was something between $300,000 and $500,000, correct?
I think that's correct. I'm not sure if I was referring to how much I had been paid to that point in time, or I think the question I had been asked about compensation was how much I expected to have been to be paid by the end of the trial. I can't remember exactly what the question was, but there was an estimate. And I believe the estimate I gave was in the range of $300,000 to $500,000. I think that was the estimate for till the end of this trial.
It's kind of strange that he was like hemming and hawing and just stammering over the answer to that question. And there's no way to know exactly how much money he's made, but he's definitely made between 500,000 and $1 million for that one case, right? And he's been hired again and again and again. So multiply that across dozens of trials, and all the same names appear over and over. Kolodny, Lemke, Franklin, Ballantyne, Sullivan. Even Mendel was an expert witness, although he says, I think he was unpaid, or Adrian Few Berman. I mean, this is not about science anymore. This is truly a business model. It's a business plan, and it's an entire industry, the litigation industry, the expert witness industry. And we're all still talking about Purdue Pharma, like media, podcasters are still talking about Curtis Wright and the revolving door of the FDA. But meanwhile, this other revolving door between key opinion leaders and courtrooms and policy power has been left wide open. And I mean wide open. And these people write the narrative. They testify under oath that OUD is everywhere. They serve as these highly paid expert witnesses in lawsuits. And then they help push policies that expand a diagnosis and force treatment. And all of it is backed by this shaky data and these hidden financial ties. Just kind of to recap this loop a little bit, a fake crisis was created by redefining addiction, inflating the numbers through the DSM and the NSDUH survey, then weaponizing that narrative in the courts where prop-affiliated key opinion leaders like Kolodny, Lemke, Ballantyne, Sullivan, and others made $500 to $1,000 per hour testifying in opioid litigation, and they're serial expert witnesses. So remember what Stanton Peele had said. They created this epidemic, right? They created a solution to an epidemic they invented. So I want to play a clip from Barry Meyer. I can't stand this man. He is a journalist, and he wrote Painkiller, that stupid series that came out on Netflix not that long ago. He wrote the book about it years ago.
So companies, when they get in trouble, hire people called crisis management experts. So it's up to me as a journalist to create a crisis, and then it's up to the company to hire these PR people who are supposed to manage the crisis.
So there you go. So not only did they create the diagnosis in DSM and the inflated statistics, and they invented this crisis, and now they hire journalists like him to create this massive panic in crisis in media. And we all know the crisis was addiction. The accused was Purdue and doctors. The solution, conveniently, was the very product and treatment model pushed by these same key opinion leaders that were funded to do all of this stuff. This next clip is Lisa Cosgrove again, and someone was asking her about key opinion leaders.
That's it. But some of the people involved are what are known as key opinion leaders, aren't they? So, they're really quite important figures in the field of psychiatry. And one gets the sense that they're acting almost as a marketing tool rather than a kind of tool of science.
Yes, that's a very important point. There are key opinion leaders in all areas, right? Nike knows that to sell sneakers, they're going to tap a very famous athlete. And in much the same way that Nike knows that, so too do the pharmaceutical company executives.
Yeah. And we all know who the key opinion leaders are, as we just named them as expert witnesses. They are used as marketing tools, but not just for drugs. They're used as marketing tools for litigation, for treatment mandates, for surveillance, including companies like Bamboo Health and NarxCare and the Suboxone pipeline. I mean, Gary Mendel wrote that PDMP E8 electronic health record integration white paper like 2016 or whatever. These are the key opinion leaders that are pushing industry and funded. Like Shatterproof is funded by these same exact companies that funded all of this. He's heavily funded by Alkermes and Indivior and all of these other industries. Just because I love this clip so much, I want to play that Stanton clip, Peele, one more time.
So we've created a solution for a problem that we invented.
That's right.
We created a whole new problem, and it causes death.
I mean, perfectly said. A crisis invented, a solution prepackaged, and the beneficiaries, who are they? They're not the patients. They're these key opinion leaders in the pharmaceutical companies and the systems that they could control. So that brings us to the next phase of this story, of course, which we've been speaking about the whole time, but we're going to go more in depth about Suboxone. That first motive was litigation, and this next motive is Suboxone, and not just how Suboxone was promoted, but how it became mandated and marketed as a miracle and flagged in things like narcs care surveillance systems, all at the expense of pain patients and anyone refusing to play along. And that includes our doctors who don't push us onto Suboxone and continue our medication. Our beloved Suboxone is the next obvious industry that benefited from all of this, because it wasn't just about rewriting the DSM. It wasn't just about inflating the NSDUH numbers. It wasn't just about litigation. It was also about ensuring that the solution was already waiting. A solution that was sold by the very companies funding the key opinion leaders, the research, the training, and even the media narrative, as you heard by Barry Meyer. And Suboxone was this answer in waiting. And then they help shape federal guidelines that mandate treatment based on the narrative they sold. This was never about solving a real epidemic. It was about manufacturing one with the solution already there. They already had it created. So I'm calling this next section Suboxone, the mandated miracle, the cure you didn't ask for to the disorder you never had. Let's say that you're a chronic pain patient and you're taking your medication exactly as prescribed. You're stable, you're functioning, you're thriving, and suddenly you're given a diagnosis of a use disorder and you didn't feel addicted. You weren't misusing your medication, but congratulations, you now meet the criteria of opioid use disorder because you're on a certain dose, or you've been on it too long, or you refuse to taper. And what's the treatment? Well, that's the one-size-fits-all solution that everyone seems to agree on. So I'm going to play this clip here from that Australia video that I showed at the very beginning.
Fergal is going to be talking more about a more integrative approach and the use of buprenorphine. And I'd like to just say a couple of comments. Buprenorphine is widely used as a dependency treatment, and in patches and low-dose like Temgesic, it's used as an analgesic. But in fact, while it's said to be a partial agonist, its efficacy in humans is the same as full mu opiate receptor agonists, and it also seems to have hyperalgesic properties. It also has the bonus of a lower risk of respiratory depression, and if things go awry, it gives us an off-ramp into addiction care.
That's right, an off-ramp. You're off-ramped into addiction treatment for the crime, taking opioids for your pain, and the final destination of that highway is Suboxone. This other clip I already played before, I believe, but I'm going to play it again from Kolodny.
Lastly, what I will say is why I do think it's important to call it what it is. And if people meet the DSM criteria for opioid use disorder, why we should use that label. I know there are many doctors who feel that they're stigmatizing a patient. They're putting a brand on them by giving them the stigmatized diagnosis. But I think that when we don't use the correct diagnosis, that many patients wind up not getting treated. And for the people with the more moderate to severe opioid use disorder, the ones who have difficulty controlling their use, many are going to be at high risk of death if we don't give them the proper diagnosis. It's hard to see that people get evidence-based treatment if you don't really give them the proper diagnosis.
And this next one.
And for those who are addicted, we have to see that they can more easily access effective treatment. I was short on time, so I didn't discuss it, but
here it comes.
But that first line treatment that we should be making readily available to patients with opioid use disorder is really buprenorphine, which is a really good treatment option for the chronic pain patients who are stuck on opioids.
Yeah, stuck on opioids. And notice he used that expression first line treatment. Do you remember Lisa Cosgrove and Dr. Davies both said that when they investigated the funding on the DSM, that 100% of the people who were on the work groups of those disorders like SUD or OUD, where medication is the first line treatment, 100% were funded by pharma. So, can you trust it? I don't really think so. But I mean, they love to claim that Suboxone is great for pain patients, even if they're doing fine on their regular medication. I mean, you can almost hear this like marketing pitch. I always hear this in my head with him of like, oh, well, you're not addicted, but this miracle drug will save you from your stable condition. The miracle of Suboxone. It drives me crazy. Now, I'm going to play another clip here this is Dr. Lewis Nelson, another one who is an expert witness in opioid litigation. He was on the CDC guideline work group in 2016, and he never disclosed his expert witness work. And this is a quote, a clip from him. I think this was a news conference or something.
Now, chronic pain is a little bit different as opposed to acute pain, because there's usually a long legacy of findings that are associated with drug use. Patients are often upfront, and when you ask them about it, they'll tell you. And what those patients need more than a prescription for a new drug is referral to an addiction specialist, to a rehabilitation or detoxification program. Those are available, and we like to refer people to those. Often patients aren't willing to admit they're ready for that yet.
Ready for that yet. That's always what they say. They're not ready for that yet, right? Yeah. So all they need is addiction treatment. Addiction medicine has taken over healthcare in this country, especially pain care. It's disgusting. This next clip is from Jamie Boyle. I don't know if you guys remember, within the last few years, we made a bunch of videos about a film called Anonymous Sister. Jamie Boyle wrote this film. Her mother and her sister were apparently developed an addiction from prescription opioids. I think it was OxyContin. And she wrote this, she did home movies, and she made this film about it. And she hooked up with Kolodny early on in the process, and he of course was her advisor, and he's at all of these showings and in the panels, and it's so bizarre. Like, she quotes him like she's a Manson girl. You know Charles Manson, and you ever see the girls when they talk about Charlie said, that's how she's like. She's like Andrew said, like she's some weird freaking Manson girl. It's very creepy, really, really creepy.
That, and Andrew says often, if you can, it's very hard, but if you can get pain patients to switch over to medication assisted treatment or off of them, their pain usually improves.
So they just need Matt, Andrew says. And I'm going to play another clip by her. This one is worse than that one.
The solutions are so complicated. I can't name one. Yeah, there's still 10 million people on long-term opioids for a drug that is not safe or effective. Effective being a huge...
So first of all, the drug is safe and effective. There is evidence that it's both safe and effective, but she's been sold the lie, the propaganda that opioids don't work for pain. And the 10 million she's talking about are the 8 to 10 million on opioids that I told you before, chronic pain patients.
Term there, 10 million Americans, that's insane to me. And that every medical professional understand this disease to the degree that they could treat them, that the people who do make it out and their family members could go and get the kind of care. Like, I'm educating like some of the best doctors in Colorado on opioid use disorder every time they go to the doctor. I don't understand how that's still possible. That would be.
Yeah. No, what's insane to me is not that there's 10 million left on opioids. What's insane to me is that you, Jamie Boyle, are educating doctors based on your indoctrination from Andrew about opioid use disorder when he's a paid mouthpiece for pharma, and you don't even realize it. You don't even, I'm not going to say you're stupid, because I don't think you are, but you really don't realize that you've been used by industry to push a pharmaceutical product. And making you think you're saving the world when you're actually causing massive amounts of harm. Before how we played that Coelho clip saying that he had a low threshold for diagnosing opioid use disorder, right? They kind of lower the bar when it has to do with chronic pain patients. And he admitted it. If you're on opioids and you won't taper, that's opioid use disorder, which that's not what it's really true. In that, to me, that's scientific fraud. It's not that, oh, I don't want to taper because they're working for me. It's, if you don't taper, you have opioid use disorder. And we've said this before, that they've successfully indoctrinated everyone that opioids don't work for pain. So if you have a patient coming to you and you're a doctor and your patient says opioids work for my pain, well, they already know that that's impossible, right? In their mind. So you've got to be lying. You're either drug seeking, malingering, diverting, or simply addicted, and you just need Suboxone. That's their answer to get you like out of their hair. Right. And let's listen to this one clip, this other clip by Paul Coelho about what happens with the patients he puts onto Suboxone, because he forces everyone onto Suboxone if you're over a certain amount of opioids, even if you're stable. He doesn't care.
So we don't. So I consider it a rotation with the caveat that we're never going to rotate back. Because once I put somebody on buprenorphine for opioid use disorder, I'm very clear. This is a lifelong, chronic, relapsing, remitting disease, and you are never a candidate in my clinic for chronic long-term opioids again for chronic non-cancer pain, ever. We're not going back. You can't, opioid use disorder is like cancer. It may go into remission, but you're never cured of it. So they're not appropriate for full agonist opioids ever again. So when I say it's a rotation, it's really a one-year rotation. And that's kind of how I do it.
So that's the thing, right? OUD is a chronic brain disease, which I don't agree with. It's not a disease. But if it's, let's just, for argument's sake, say it's a disease. So you're fraudulently diagnosing with someone with a disease, which then leaves them having to be cut off their medication and put onto Suboxone. So you're giving them a medication, you're punishing them for a disease they don't have and giving them a medication to treat a disease that they don't have. And you think it's funny somehow. I don't think it's funny. It's really not funny, because you're harming people. You're causing massive harm and really death. And to say, oh, once you're there, that's it. You don't go back. You're locked into Suboxone for life. It's not a bridge. It's not a tool. It's a tunnel with no exit. You're there forever and ever, and lose your teeth in the process, but they don't care about that. Let's not forget, this whole time we're calling Suboxone life-saving, evidence-based, stigma-free. And the Narcs Care algorithm quietly flags you as high risk and overdose risk and too risky to be giving opioids to. So let's just recap a little bit before we move on to the next section here. If you stay on opioids, you're flagged. If you refuse to taper, you have opioid use disorder. If you accept Suboxone, well, you're flagged anyway. And if you try to get off Suboxone, then you're non-compliant. I mean, this isn't care. This isn't medicine. This is simply an industry-funded narrative. That's all that this is. This next section I'm calling Selective Skepticism. Why did they look away? Conflicts for me, but not for thee. I'm going to talk about something that drives me absolutely crazy. And I must ask Carrie Judy, who does this research with me all the time. I call her my researcher partner in crime. And every time, probably every day, I'm like, Carrie, how come these people are calling out these conflicts, but they don't even mention addiction medicine? There's psychiatrists, Lemke, and people, this is what they're doing, but they ignore the conflicts in addiction medicine. These are the watchdogs, the skeptics, the people who are supposed to be calling this out, but they're curiously silent when it comes to addiction medicine and Suboxone and the DSM and the NSDUH and all of this. So I'm going to play a clip from Adrienne Few Berman. She's the founder of Farmed Out, which is a group that claims to expose all of this, like pharma funding, right? For CMEs and pain organizations and all of that. And she always says to avoid sources of information funded by pharma. So let me play a quick clip for you here. Oh, she was also a serial expert witness, but that's beside the point, I guess.
Dr. Berman, in the film, we see some of the factors that allow the opioid epidemic to take hold, many of which have been debated and politicized. Where can people find good factual info about drugs and policy that they can believe in?
So I think the most important thing is to avoid any sources of information that are influenced by industry. And certainly Purdue Pharmaceuticals and other pharmaceutical companies, used consumer advocacy groups. They used professional medical associations. There were all of these pain societies. They got key opinion leaders to write articles in the medical literature supporting opioids. So and even now, industry really controls most of the information that physicians get, not just about opioids, but about other drugs and diseases as well. So it's really important to get information from groups that don't take money from industry. So groups like PROP, Physicians for Responsible Opioid Prescribing, and Shatterproof, and Farmed Out has information as well. But really, for any drug too, you can become much more of an expert on.
Okay, so first of all, Farmed Out was funded by the Attorney General Fund that was established from suing, I think it was Pfizer. So she was funded to be a group, like a AstroTurf group, to sue pharmaceutical companies. That's number one. Avoid information funded by pharmaceutical companies and, get your information from PROP. Every single person in PROP was an expert witness. And Shatterproof, who doesn't get pharma funding, which is nuts because they're truly funded by pharmaceutical companies, Indivior, Alkermes, Pacira Pharmaceuticals, Adapt Pharma, I think Emergent also. So I don't know if she was lying or just she doesn't know, but it's crazy. Naloxone is an opioid, in case you guys weren't aware of that fact. So this is an opioid funded narrative, just not the opioid of your choice, right? You love this opioid, but you want to punish anyone on any other opioid. So it's not evil pharma, it's evil pharma versus good pharma, whatever you determine is good. I'm going to play another clip. This is from Few Berman again. She was at Claire McGaskill. She investigated pharmaceutical companies' ties to pain organizations. In 2018, Dr. Few Berman testified before Senator McGaskill, and she urged Congress to investigate pain advocacy groups. She accused them of being industry funds, and she didn't even give her own disclosures here. She didn't say she was an expert witness in opioid litigation, but let's hear what she has to say here.
There's not enough attention paid to people who actually are victims of adverse drug reactions and misuse of drugs, but there's a lot of attention that's paid to sufferers from diseases. There are many fake consumer advocacy groups. There's a lot of corruption of professional groups. We really need to have transparency of payments from pharmaceutical and other biomedical companies to consumer and professional groups, and those groups should be required on the 990s, on the SEC forms, to disclose exactly who is giving them money. That would be very useful.
Yes, I agree.
Useful for.
Yeah, so we should write a letter to them and ask them.
That would be really, very useful for the future, and we need.
So yeah, let's get the list. If you can help us with the list of some of the advocacy organizations that you think are in the process of being bought off by these pharmaceutical companies, that would be terrific.
It would be a lot easier to give you a list of the ones that aren't. There are thousands of thousands of advocacy organizations taking money from pharma, and there's about 17 that are not.
And I guarantee you, none of them on her list have anything to do with the addiction industry.
That are not. But that's an area that we're working on as well. But that would be an area to address legislatively, and if there's any way legislatively to separate to separate industry from health professional education.
Yeah, I'm with you, Few Berman. I agree with you. I think that every nonprofit advocacy organization should have to put on their 990 who they get their funding from. We do. And we don't get any funding. So why shouldn't addiction organizations, and this McGaskill hearing led to an investigation from pain organizations and ties to pharma, and all of their funding was listed at the end. In Wyden's report, it was the same investigation. And at the end, he was like, we need to have full transparency where we need to be able to see what advocacy organizations, nonprofits get from pharma. And he was talking about pain organizations, but why just pain organizations? Why not addiction? I want to see a list of these addiction organizations and their ties to pharma. I want to see their funding from Indivior, from Alkermes, from Pacira, from everyone in the opioid elimination industry that has benefited from this false narrative. I want to know all of them and how much money they're getting from pharma. Yeah, that's what I want to know. So this next one is funny. Dr. Keith Humphreys, he's out of Stanford, and he has been very influential in drug policy for decades, I believe, for many, many, many years, decades. This was a clip from just a few years ago. There's a few clips I'm going to play for you, and then I'm going to explain to you why this is just so funny to me.
Last thing is, what about the influence of the pharmaceutical industry? And to be clear, I'm speaking for myself, not officially for Stanford or the VA. This is my opinion. The pharmaceutical industry has too much influence on how medicine is practiced. So I feel when I read papers, and there's been some really disturbing things of like a medical school finding out that an opioid manufacturer was funding their pain course, and it included content endorsing their products, and neither the students nor the faculty were told that, I feel furious. That's just, to me, outright corruption. And it results in people being harmed. That should just not be possible. It should never happen. Sure, pharmaceutical industry, they can donate to medical education, but it has to go in a fund that they have zero control over. And the people who actually understand healthcare should be in control of that. I mean, the pharmaceutical industry does a lot of terrific things. They've saved zillions of lives. I'm grateful to them. But at the same time, they are the force, particularly, that went into doctors' offices and told people you can prescribe more and more of these things, don't worry about going too high. And that was wrong, and they shouldn't be allowed to do that. And we need to have restraints on that. I think we need to have restraints on advertising. That's very hard to do in the United States. Our law tends to look at advertising as a form of free speech. That is why we're one of only 2 countries on earth when you turn on the TV, you see ads for drugs. I don't see why it has to be that way. I think it's great we've got all these drugs, but I don't know that it's good for us to watch the evening news and just be bombarded over and over with the message, whatever your problem is, ask your doctor about a pill. Whatever your problem is, ask your doctor about a pill. Get more pills. It's not going to pills for everything. I don't think that's good for any of us, and I would like to see that restricted. I don't think that hurts anybody.
Okay, let's go to this next clip.
Maybe it hurts if you own stock in a pharma, but beyond that,
I want you to keep that in mind, okay? Maybe hurts if you own stock in pharma. That's important, and I'll tell you in a bit why.
I think the gain to public health would be very good, and restoring the trust in medicine would also be very good, because medicine's taken a big hit reputationally, and it deserves it. It's part of this problem, right? But part of recovering from that is being honest about the potential influence of money, and it's really enormous. I know I have beloved physician friends who I know are very honest people, and they say those visits from the detailers and the gifts have no influence on my prescribing, and I believe that they believe that. But I know that they're wrong because the companies know exactly how much everybody prescribes, and they can see what works. That's why they do it. They're not spending that money for charity. They're spending it to push their products. So that's part of the puzzle here of how do you allow, it's great to have a pharmaceutical industry. We want to have that, but how do you do that in a way that does not end up with the dollars basically sacrificing our health, which is what has happened with opioids.
Okay, and one more here.
We also had problems with what are sometimes called astroturf groups, which means fake grassroots. The tobacco industry pioneered this with smokers' rights groups, who would show up at hearings. I'm just an ordinary citizen, and I just want to say I love Marlboro's products. They're great people, and I've come to that conclusion freely and independently. So we had that a lot in this domain with groups representing patients who said they were the independent voice of patients, to quote what the American Pain Foundation said, but they were creatures of the industry. APF actually had to close down because the Senate did an investigation, found their budget, I think it was 88% of their entire budget was given to them by the pharmaceutical companies. And there's some amazing releases in some of the lawsuits now. You can see the emails of executives saying to these groups, we're on your board and we will tell you what your independent views are. We're paying the bills. And some of the people didn't even realize, like they thought it was a genuine grassroots group, but it wasn't. And this still happens. By the way, it doesn't just happen in this domain, but it's a general problem of, there are real grassroots groups for sure, but there's also a lot of fake ones. So what should be done about this? We have a lot of recommendations, but here are some of the big ones. To really curtail pharmaceutical product promotion. There are countries where they just don't do that. Like in Germany, a doctor cannot accept anything that could influence prescribing or anything that looks like it might influence prescribing, even just looks like it. And they can't accept anything not just that is to affect future prescribing, but also anything that could be construed as a reward for prior prescribing. We could just make this illegal and have to have those wonderful, charming, well-dressed people running into all these offices getting doctors to prescribe everything. There would be, could be challenges to that on free speech grounds. We have a particular way of handling speech that is different from other countries. That's why we have ads on TV with the pills on them, and hardly any other place on earth does.
So these are bold words by Keith Humphreys, right? We must remove pharmaceutical influence from policy. Industry has no place writing the rules. We have to expose AstroTurf organizations. The only ones who are going to be harmed are those who have shares in pharmaceutical stock. Remember he said that? Let's fast forward a couple years here. And Dr. Keith Humphreys now sits on the board of Indivior, making easily 6 to 7 figures a year. The maker of Suboxone, the drug that he often pushes in his lectures. He also owns over 4,000 shares of stock in Indivior. So I don't know. It's kind of funny because he's sort of making fun of his future self and he didn't even realize it, right? But even with these conflicts of interest, he's still advising policy. He still writes op-eds. He's still a go-to expert. He still appears as a neutral expert with no disclosures of these conflicts. In the recent podcasts he's been on, there haven't been any disclosures of either his shares or sitting on the board. And I tweeted about it last week and he blocked me. I mean, weird. It's weird. You call these people out and they block you. I guess I don't like transparency, really, do they? Review really fast here. Just recap. Purdue-funded pain organizations, that's bad. Indivior-funded addiction organizations, that's good. Financial conflicts in pain care, that's corrupt. Financial conflicts in addiction medicine, that's good and evidence-based. This is not just hypocrisy. This is professional gaslighting. And pain patients are the casualties. We are the collateral damage of all of this. And when the same exact people who shout about transparency and corporate influence go quiet the moment it touches addiction medicine or Suboxone, that's not really an oversight. This is not, oh, we missed it. This is a cover-up. This is an obvious cover-up. So that's what I'm talking about, this selective outrage, the selective skepticism. Investigate pharma unless it's about Suboxone. Expose conflicts unless it's about Suboxone and addiction medicine and substance use disorder, diagnosis, and all of that, right? Expose conflicts unless it's their conflicts. Demand transparency unless it ruins your next consulting gig, right? That's how this is, isn't it? That brings me to our next section here, and this is about Narcs Care. As many of you know, we recently filed a citizen petition to the FDA to regulate Narcs Care. This has been something we've been fighting since 2017, since I came into this fight. This is one of the very first things I learned about that I've been fighting against. And this all ties in together because once you're put on Suboxone, Narcs Care reads it as too high risk and you're put off. You're cut off your medication. Let's connect that final dot here for you. You've been misdiagnosed with OUD using vague DSM criteria. Your data is reflected in the manipulated NSDUH survey. You're told Suboxone is the only answer, thanks to these key opinion leaders with undisclosed ties. And now it's all plugged into Narcs Care, a secret algorithm scoring you in real time. You didn't just get diagnosed, you got flagged, you got scored, you got added to a digital watch list, and then it gets worse because Bamboo Health, the company behind Narcs Care, doesn't just monitor risk. They also run a program called Open Beds. And if your Narcs Care score is high enough, your doctor could literally see a pop-up that comes up there on his screen that says, this patient is a high overdose risk score. Here are the available treatment beds. Translation, here's where we can send them to be started on Suboxone today. It's unbelievable. It really is insane that they've been allowed to do this. So I'm going to break it down one more time. You're misdiagnosed. You're scored. Your provider is nudged to put you into treatment. You're placed on Suboxone. That raises your Narcs Care score by 30%. Now you're permanently flagged and you'll never be given a regular opioid again. Remember what Coelho said. This is a one-way rotation to Suboxone, a one-way trip. He wasn't joking. Once you're in this system, you're not getting out. There's no way out. And all of this is happening without patient consent, without regulatory oversight, without transparency. I mean, Bamboo might call it innovation, but I think it's coercive care disguised as data-driven medicine. This is why we filed this petition. I am so passionate about this petition. I think of everything we've done, I'm most proud that we were able to do this. Now, I don't know that it's going to accomplish what we set out. I don't know that FDA is going to regulate it, but I do know that we need you to comment. Please comment on that docket. All of the information will be linked here for you. But this is why we're asking for oversight, because this isn't just about pain care. This is about whether algorithms can really end up dictating your treatment for life. Right? So it goes from the DSM to the NSDUH to Suboxone to Narxcare to open beds and back to Suboxone. It's crazy. So this is our call to action. What do we do now? Now that we know all of this, what do we do? I mean, they created it, they profited from it, and now we expose it, and then we figure out a way to stop it. This is the plan. We must expose it. We've got to document. We've got to keep calling this out. Someone will listen. I am 100% convinced that someone will listen. As long as we keep it factually based, we keep putting those facts out there, someone is going to notice. So in this video, we walked you through all of it. The vague DSM criteria, the inflated NSDUH survey, the expert witnesses, the profiteers, the Suboxone pipeline, and the medication for opioid use disorder mandates, the closed loop algorithm punishment of Narxcare, and the ongoing cover-up by these selective skeptics like Few Berman. This wasn't just a policy failure. It was a calculated system of misdiagnosis, misrepresentation, and manipulation. And here's what we're doing about it. This citizen petition, this is step one. We have asked FDA to reevaluate Narxcare to see if it truly is software as a medical device, which it should be, and to regulate it for some oversight. See, they never approved it. No one approved it. No one regulates it. No one. No one has to know what goes into it. But it meets all of the criteria for software as a medical device, but it has zero oversight by anyone, including the FDA. So we're asking for transparency, regulation, which will lead to patient protection. And in the process, we're building public awareness. This video is really part of a broader campaign to expose the infrastructure behind the OUD crisis narrative, the why, the blueprint, the how this happened. We're not talking about a few bad apples here. We're talking about a machine that was built to profit and punish in the process. We plan to ask for federal investigations. This FDA citizens petition, this is just the start. We're not stopping. We're not going to stop. And we are calling you to get involved. We are asking you, we are begging you to get involved. Please comment on this docket. At the time that I recorded this video, we have 573 comments, I think. We really want to hit 1,000. We have until May 10th. We should be able to do it. Share this video, share the petition, share the docket. Let's see. Contact your legislators, demand transparency from the FDA for Narxcare, and support independent research. Call out the pharmaceutical conflicts of interest on all sides of this crisis. I have no problem with pain organizations being transparent. They should be. Every organization should be. We all should know who funds what. Right? We should know who wrote the DSM-5, how much money they took, who they took the money from. We shouldn't be excluded from that. R-Not 90 is on the website. And in case you were wondering, we don't take any industry funding. We don't take any funding. We don't take grants. Our funding 100% comes from your donations and your support, mostly from our Patreon page, which is patreon.com/the Doctor Patient Forum. We are so grateful for your support and we hope you're enjoying the content. and I enjoy doing it and connecting with you guys. The community is amazing on Patreon. It's so kind and encouraging and supportive. The fact is, this isn't just about pain patients anymore. It's really about every single person in the system who, you can be flagged now and misdiagnosed and denied care because of this profit-driven algorithm decided that they were risky. And here's the thing, our tax dollars are paying for narcs care. That's how it's paid. And it's such a waste. It's such a waste. But you know what? We're doing what we can. I'm encouraged. I'm excited that we have this petition there, that we have this number of comments. Thank you so much for watching. I'm going to give you these closing words. They told us it was about safety. They told us it was about evidence. They told us we were broken, but now we know better, and we are not asking for permission to fight back. So join us on this fight. Join us on our Facebook, the Doctor Patient Forum page. Regulations.gov is where you can comment on the docket. Just search the Doctor Patient Forum and find the citizen petition. I'll give you all the information attached here. Help us get the word out. We can't do this alone. We need all of you. Thank you so much for watching. Have a great day.